again, good morning, ladies and gentlemen. Welcome to this inaugural meeting, symposium of the East African Gastroenterology Symposium. I think it's a new thing and very important, which we are going to have today, because for the first time, we are going to discuss these issues of gastroenterology with people from Tanzania, Uganda. I think our colleagues in Kenya are joining online. Absolutely. So it's an East African thing which we are starting today. So gastroenterology is an important area of study because it covers from physicians, surgeons, even us microbiologists are part of it. So we are going to have almost half a day or full day of discussion looking at all issues about the burden of disease, how do we diagnose it, and how do we manage it. So we'll try to walk you through this, through the program which has been prepared. So I would like to invite Dr. Muhyiddin, the President, the CEO or SG of Jamii Bora, who are organizers of this, to welcome us and give us the overview before we proceed. Then I'm going to invite the President of the Tanzania Gastroenterology Society to give a keynote speech, and then we'll wrap up knowing what we are going to have all of this today. So welcome Dr. Muhyiddin for a quick welcome note and overview. We have started late, but we are going to do all we can to finish on time. So, karibu.
Thanks very much, Dr. Ipuge, for starting this event. So, ladies and gentlemen, a very good morning to all of you. My name is Dr. Muhyiddin Mahende, standing here on behalf of our organization, Jamii Bora Health Service Network, which has been an organizer of this particular event of the day. Our organization comprises of Muslim health professionals across the country, across all the disciplines and cadres, and we have been moved since 2017 when we were registered, and our work has been mostly on how we can bring some services, especially to underserved communities. We have been engaged in a number of activities ranging from medical screening and treatment, public health education, and also sometimes we also do some relief and charity works. Our contribution in the public health arena in the country has been significant in a number of areas, and we're recalling the good work which we did during the pandemic of COVID in the year 2020 and 2021. We worked collaboratively with other organizations as well as the government in minimizing the effects of the scourge back then. As for today, it is both an honor and a privilege to myself and our organization to stand here on such a distinguished gathering whereby healthcare professionals, stakeholders, and other public people or the general community, researchers, and other people trying to have a dialogue on some issues pertaining to digestive health in the region. For us as an organization and to our sponsors and other partners, it's a good and significant day and an important milestone whereby we could have some of this gathering now and then where we can meet and discuss and have a deep delve discussions on various aspects pertaining to gastrointestinal issues. The event for today, we expect will reflect our shared commitment to collaboration, knowledge sharing, innovation, as well as putting forward efforts in improving the livelihood of the people by having updated, innovated, and updated information, approaches, treatment modalities, and also diagnostics. We believe together we can accelerate the progress in diagnosis, treatment, prevention, and ensuring that even the people at the most remote communities may benefit to upcoming interventions, especially in this particular area of digestive health. We therefore especially so grateful to the esteemed people who have made here today to come and talk together with us. We appreciate the support from our sponsors, Headway, RIMA, Yamibora, Yes, and others. We appreciate the people who devoted their time to be speakers for today, presenting various topics as we will hear as the time goes. We appreciate for a number of people in the room who will lead a panel discussion which will go around some issues on public health, policy issues, prevention strategies, and also innovative approaches towards management of digestive health in the region. Your contribution today, each one of you in this particular room, is undoubtedly will shape the conversations and actions that may follow a long life to this event. On behalf of my organization, Jamibora, our partners, RIMA, Headway, and others, Yes, SMV, and others, we welcome you all to this particular event of the day, and we hope the event will promote new ideas, will give us an opportunity to learn, share expertise and experiences, and make sure that while we leave this door at the end of the day, we are very changed in the way we think and our approaches towards digestive health in the country. Having said that, I would quickly acknowledge the support of some of the organizations and people in this particular room who have made this event to this minute possible, as we have still some time to go until the end of the day. First and foremost, I would like to welcome to thank the Gastroenterology and Endoscopy Society of Tanzania, which has been our pivotal advisor and support to making sure that we gather here today. We also acknowledge the support from our sponsors, Headway, RIMA. We also acknowledge the support of the people from the telecommunications, Yes, who has enabled the communications and some form of internet connectivity in this particular room, whereby some of the people who will be joining this meeting virtually will be able to follow each and every step which is going on in this particular house. I would like sincerely to recognize the speakers, as I said earlier on, the panelists and others who will be here this particular day. And especially I would like to say thanks to our fellow Anthony from Uganda, who just flew yesterday to come and be part of this historic event today. I would also thank my seniors and my professors. I'm seeing them in this particular room. Colleagues, Dr. Mahita, Dr. Zaitun, and others. We welcome you all in the meeting, and we hope we're going to have a very fruitful and very charming conversation in this particular day. Having said that, ladies and gentlemen, thank you very much for listening. Thanks.
Thank you very much, Dr. Muhidini, for kicking start the meeting and recognizing a few of the members here, but doesn't mean that the rest who have not been mentioned, they are not recognized. We recognize you all, and your presence will make our event today fruitful. So in our midst, we have the president of the Tanzania Gastroenterology and Endoscopy Society, Dr. Edward Okomba. He's a physician. He's a gastroenterologist and a hepatologist. He's working at Muhimbili University of Health Sciences as a senior lecturer, but also head of internal medicine. He's a founding member of the Tanzania Gastrology and Endoscopy Society, but as I said earlier, he's now their president. So we welcome him. Let me welcome him to give us the keynote speech for today. Karibu, Dr. Komba.
Oh, thank you very much for the invitation. I'm very honored. As I was introduced, Dr. Just a small correction, Ewaldo Komba, not Edward, Ewaldo Komba. As he said, I'm the current president of Tanzania Gastroenterology and Endoscopy Society. And as he correctly said, I belong to the MUAS, that is the university, the medical university, and I am the head of Department of Internal Medicine. Distinguished guests, esteemed colleagues, ladies and gentlemen, I greet you in the name of the United Republic of Tanzania. Kazi endele. Yeah, it is an honor and a very big privilege to stand here before you today at this very important gathering of minds and hearts dedicated to advancing gastroenterology in East Africa, not only in Tanzania, but in East Africa, of course, and the world at large. As we come together for this one day, yet very fruitful symposium, we are not just sharing research and innovation. We are here to learn, to share, to experience, and gear up the shaping of the future digestive health in our current times as well as in the future generations. In recent decades, we have witnessed remarkable progress in the diagnosis and treatment of gastrointestinal disorders as compared to the past, whereby several challenges obscured care and treatment. In the ages where diagnosis in most parts of our practice relied solely on clinical presentation and merely simple diagnostic approaches, this was followed by a progress in the development of point-of-care and rapid diagnostic tools for detecting active infections, for checking antibodies and antigens, or specific markers for certain diseases. But as of now, readily available simple tools like the urea breath test and others have been very instrumental in aiding healthcare workers in decision making. And today I can see we have this tool here, urea breath test. Has never been in Tanzania, but I think now it is coming. All these are to improve the diagnosis and management of our patients. But the biggest challenge now that we have is how to make these interventions and innovations and working tools available at all necessary levels of services and care provision. Some of them are a little bit too expensive, some of them are difficult to obtain, but I think as we advance, all this will be in place. As we know, the evolution of endoscopy procedures and techniques was with the integration of imaging, artificial intelligence tools, and robotics. Our field has continuously adapted and innovated. We now have tools that were once the stuff of dreams, like capsule endoscopy, molecular diagnostics, and biologics that target the disease at its source rather than just alleviating the symptoms and the signs. Like these days, we have drugs like bevacizumab. It's a very good one for colorectal cancer, and our patients are actually receiving it at Ocean Road, covered even by our insurance companies. So all these are advances in endoscopy. This is a big achievement and, of course, a breakthrough in improving services and care. Yet, despite these advancements, we face growing challenges. For example, the global burden of gastrointestinal disorders, ranging from inflammatory bowel diseases and colorectal cancer to liver cirrhosis and functional GI disorders, continue to rise. Healthcare disparities, late diagnosis, especially for our patients with cancers. Many research in Tanzania have shown cancer patients arrive at hospitals in stage 3 and stage 4, which is very late even to assist them. All these are some challenges that we face in this advancing gastroenterology and gastrointestinal endoscopy services. Also, we have limited access to the cutting edge therapies in low resource settings, including Tanzania. All these are hurdles we must overcome together. Now, the future of gastroenterology demands more than innovation. It demands collaboration. And that's why when Jamii Bora approached me as the president, I said, yes, if we are collaborating like this, then we can achieve more. We must break these silos between research and clinical practice, between public health and personalized care. We have a lot of research data, but it is kept in the shelves instead of collaborating and make it useful in delivering care to our patients. Our collective efforts must focus on early detection of diseases, preventive strategies, and patient-centered care. Not like in the past. The care should not be centered to the institution or to the doctor. The first thing to consider is the patient. We need multidisciplinary collaboration, data sharing, and global clinical trials that are essential to delivering real impact on the ground. We are also at the dawn of new technological era. We know about artificial intelligence, big data analytics, machine learning, and telemedicine. All these are redefining how we approach gastroenterology. But let us remember that technology is only as powerful as the compassion with which it is applied. At the heart of every innovation must be the well-being of our patient and their caregivers, without forgetting the skyrocketing costs for medical services. These days, if you have cancer and you want to see if it is spread all over your body, you have to do the PET CT scan. Do you know how much it costs? The minimum is about 1 million shillings. That is very high cost for a normal Tanzanian. But all this we have to consider. As we embark on the next phase of this symposium today, I urge each of you to be bold, to be curious, and to be open. Let us use this opportunity to challenge our assumptions, build bridges, and above all, recommit ourselves to the values that define our profession as doctors, that is, the integrity, the innovation, and empathy for our patients. Thank you, and may this year's symposium be of a special kind, and it should be a catalyst for the breakthroughs, catalyst for knowledge, and pieces of information that will benefit not just our science, but humanity as a whole. It is my hope and expectations that this kind of gathering won't last today, but should mark the new journey of similar meetings in the future, and dialogues covering gastroenterology and other related disciplines. My special thanks to the organizers, that is Jamii Bora Health Service Network, which of course extended their hand seeking collaboration with Tanzania Gastroenterology and Endoscopy Society, where I'm the president, to make this occasion a success. And really from the beginning I can see it is going to be a huge success today. We are open to future ventures in research and training for the betterment of our communities and ensuring that more bridges are built and challenges are mitigated for the society to be better, actually reflecting the name, the Swahili name, the Jamii Bora, for this prestigious organization. So many congratulations to Jamii Bora. We urge you to open collaborations with other professional societies like TEAGIC within and outside our borders. This will leverage the available talents and knowledge, aiming at creating awareness, knowledge sharing, and improved practices. So with these few remarks, I declare the East African Gastroenterology Symposium 2025 is now officially opened, and I wish the best for all of you in this gathering. Ladies and gentlemen, thank you very much for listening, and karibuni sana tupate matunda ya mkutano.
Thank you very much, Dr. Ewaldo, for opening our meeting and giving a keynote speech. And the president has spoken. He knows the gastroenterology from the mouth through the organs to the end. So, asante sana. I think he has raised some very important issues, some of them which are not belittling the others, but he talked about this being a multidisciplinary area where all of us in a way have a role to participate in gastroenterology, but he also emphasized that our services must be client-centered, focus on the people we want to serve and have empathy, but also he alluded to advances in technology which we must take into, as well as embracing artificial intelligence. Some of those which I took away, and I know you took something away from it. I understand that, Mr. Mgaya, that tea is not ready, so we will proceed with the first presentation and of our session today, which Dr. Binde, who is a gastroenterologist, originally based in Bugando Medical Center, but now is with Benjamin Mkapa Hospital in Dodoma, will present to us the burden of GI diseases in East Africa, epidemiology, risk factors, and emerging trends. Dr. Binde, karibu sana.
Good morning.
as he's setting up the technology, the event is streamed live, and there are other people following at the Zoom, which they'll not be able to speak, but they'll be able to ask you questions on the chat box, but also streamed live in YouTube, I think. Yeah, okay. So they can see us, we can't see them.
Thank you very much for this opportunity. I'm honored to be in this wonderful symposium. Today we are going to discuss on the burden of gastrointestinal disease in East Africa. My name is Ahmed Binde. I'm a general surgeon. I work in the surgical gastroenterology department. I will take you through epidemiology of the burden of gastrointestinal disease, the risk factors of gastrointestinal disease, the emerging trend, as well as we shall conclude with the lesson gained after this discussion. Our topic focuses on the eastern part of Africa, so I decided to bring out, at least to have a familiarization. The eastern part is covered with 12 countries, and they're commonly known are the 6 member countries of Eastern African Community. And some of my data will be catered through these 6 members, as well as some countries that will be with research published in online database. So to estimate the public health burden of gastrointestinal disease across East Africa, I extracted and compiled data from the Global Burden of Disease study in 2019. And this is one of the largest comprehensive study that has made wonderful work around many countries and published its data. I also extracted some of the data from the World Bank to assess the health development in terms of human and social demographic index. We went on as well as to check on the International Agency for Research on Cancer. This is one of the agents of World Health Organization with its online public database, the GloboCan. So to begin with the gastrointestinal disease, the overview, I used the international statistics classification, the ICD-10, just to have understanding what is GI disease or what is gastrointestinal disease. And based on this I don't find a single definition from the ICD-10, but the term digestive disease has been used interchangeably with gastrointestinal disease. And this refers to conditions affecting from the mouth, esophagus, stomach, the pancreas, the gallbladder, intestines, the small and large intestine as well. And it includes conditions such as infection, inflammation, the functional disorders, structural abnormalities, as well as the cancer. So we shall be discussing in the various sections in these conditions. So for the classification, one of the largest descriptive study that was published in 2023 by Wang et al. Classified these digestive diseases or the gastrointestinal disease into non-malignant as well as malignant digestive disease. This study went further to divide into hierarchy based on the causes. So diseases were classified according to the causes. And it has 3 arms, the communicable diseases, non-communicable disease, as well as injurious cause. So the digestive or gastrointestinal disease falls under non-communicable disease with its under hierarchy. The liver cirrhosis, gallbladder diseases, as you see, the inguinal femoral, inflammatory bowel disease, the pancreatitis, intestinal obstruction, as well as paralytic ileus. All these encompasses the non-malignant GI diseases. So for the epidemiology of non-malignant diseases, a study that was published by Rui et al. In 2023 studied the burden, the epidemiology of the disease, and it showed that in terms of proportion, our eastern part of Africa, liver cirrhosis picked or ranked the first in terms of non-malignant diseases, and this was followed by other upper GI diseases, paralytic ileus, and intestinal obstruction. And across the age, the liver cirrhosis still ranked the first among the non-malignant gastrointestinal diseases, followed by other upper GI system disease, the gallbladder and liver, and other pancreatitis and appendicitis according to the age. For the causes of these non-malignant GI diseases, the study that was published by Global Burden of Disease in 2022 showed that in the eastern part, the most common causes for the non-malignant were smoking, the alcohol use, the drug abuse, as well as the high index. And the alcohol use was picked more on males as compared to female in one of these burden of the disease. So the trend of this disease across the Eastern Africa, I used the estimated adjusted progress of this trend of the disease, and it showed on the eastern part of Africa, it still was actually very low in low socio-demographic countries, and it was around -3 ranging to 0. And this actually gave an underestimation of the burden of the disease, and most of the cause or this description is due to low epidemiological coverage from our study, low diagnostic and the weak screening system that we have in eastern part of Africa, resulting to shortage of data which impedes the understanding of the current epidemiological of the disease in the eastern part of Africa. So as we shift to the malignant or the cancers of the gastrointestinal disease and its burden along the East African corridor, global cancer in 2019, this is one of the largest global cancer statistics that has published most of the GI cancers as well. And the GI cancers account for 1 in 4 cancer cases and 1 in 3 cancer deaths global. And these variations across parts of the region of the world. However, colorectal cancer still ranked the first, and it was also the second leading cause of mortality in the Eastern African countries. For the incidence and mortality, the current data, well, that was published in 2025 by Lee et al. Showed that the incidences were high by the colorectal cancers by 9.6%, and still the colorectal cancer among the GI cancers picked the first in the mortality. For the etiology risk factors for these gastrointestinal cancers, a study that was published in 2024 in the Global Can database showed that the top 3 risk factors were smoking, alcohol use, and high body mass index, as well as some of the other factors that predispose to these GI malignancies were unsafe sex, high plasma glucose, and H. pylori, despite being very prevalent in East Africa, we still have a low prevalence of gastric cancer, and this brought a term of Africa enigma due to the face of presentation of gastric cancer despite the high prevalence of H. pylori infection. Another study that was also published in 2025 this year, January, by Lee et al., and it looked on risk factors for the colorectal cancer, and one of the modifiable risk factors that it looked were smoking, excessive alcohol consumption, high consumption of red meat, as well as processed foods, low intake in the fruits as well as vegetable, and high BMI. It further looked on the esophageal risk factors, and we know we have 2 subtypes of esophageal cancers, and we have the squamous cell carcinoma as well as adenocarcinomas. And on my left side, these are the risk factors that runs with the esophageal squamous cell carcinoma, and the commonest is the tobacco smoking, hot beverages, and both risk factor that is shared is the intake of red as well as processed meat. Another study that looked on the liver cancers showed that alcohol, hepatitis B and C were still remarkable in the cause of the liver cancer, and followed by metabolic dysfunction associated steatotic liver diseases. So the trend of these gastrointestinal cancers in terms of mortality as well as incidence show that majority of these Eastern African countries manifested a decrease in the trend of incidence and mortality rate throughout a study period for the past decades. And slightly were observed, there was slight increase in the trend of the disease that was observed in Uganda. The pattern in women were generally similar, although with much lower incidences. However, still we remain to have colorectal cancer ranking the first with a stable or increasing mortality rate. Esophageal cancer still has more increase in the incidence in East Africa, with a shifting trend of colorectal as well as esophageal cancer from elderly patients now to a young adult population. However, despite the H. pylori infection that has been common in Eastern Africa, we still have low gastric cancer in our population. And this is one of the African misunderstanding. All these data were published by Hyacinta Jaka. This is one of the professor from Bugando, Peng et al. And Lee et al. January this year. So due to this trend that was followed, a thought came in mind that what has happened, what has changed, and what has been there before. Now we have seen young adults getting these malignancies that has not yet been in the current years. So I looked on the peculiarities of this colorectal cancer, which is one of the highest incidences among the GI. And this shift in the epidemiology was actually explained by westernization in terms of the diet. And the picture shows now we have actually moved to most of these Western diet that we see in every corners of our streets and food shops that have been opened. Other peculiarities that the incidence being high in young population is again due to westernization and consumption of alcohol, processed meat. And still there is still a discussion that still need to be ongoing on the tumor biology and risk factors on these young population. There's still variation in the screening strategies and participation across East Africa, and these actually results to rise in these incidences and mortality. For the esophageal cancer, some of the peculiarities that I looked through, it was there's a difference in the distribution of these subtypes of esophageal cancer. And along the East African corridor, the common esophageal types cancer is a squamous cell carcinoma. And one of our neighboring countries being picked the highest country with esophageal cancer from Kenya as well as Malawi, followed by Tanzania, and the third in terms of esophageal cancer. Female young age population were more affected with esophageal cancers as compared to male for esophageal cancers. And this association was brought by estrogen and its receptor, as well as delayed impact in male due to a decrease or absence of these receptors. There's also a varying in the prevalence and modifiable risk factors among the population, and the screening initiatives being limited results to a high incidence of esophageal cancer. So the lesson gained behind this discussion is that we need to improve data. Some of the data we saw, there is a decrease in trend, but yet it's not the truth due to individual studies that have been done along East Africa. So we need to improve the data that will need to be incorporated in the globally. Endoscopy units also need to be well-established database. Routine screening programs on the GI cancers need to be well-established and implemented. We need also to improve the GI research on our East African region and screening programs that needs to be also shift from the elderly to young population with high prevalence in this age. With in mind that the decision to shift these screening modalities, we know for a long time screening programs have been done for ages above 50 and 45, but due to the trend of shifting of these epidemiological disease, we need to shift it to young. But before we shift, we have to have in our minds that this will depend on the epidemiological characteristics unique to each region before we shift. To mark the end of my presentation, this is one of the theme, motto, that is World Digestive Health Day is going to be on 29th May this month. And the motto for this year is Nourish to Flourish. And thank you very much.
Thank you very much, Doctor, for the first presentation, which you have set the trend. And now, first of all, you have set a good trend on keeping time. Thank you very much. Secondly, now his presentation is open for discussion. Karibuni. If you have any questions, but you want to introduce the president as there? Okay. Okay. We welcome mwenyekiti wa Jamii Bora awasalimie.
Good morning. My name is Dr. Muhammad Ali. I'm the chairperson for Jamii Bora, and I'm happy to be part of this a good conference, which I think we are going to learn a lot. So I'm here to listen. Thank you.
Okay, so I will invite a few questions, and then we'll allow him to respond to them, and then we can have a second round. So I'll take 3 questions or contributions. Oh, this is not a good start. Karibu, President.
Yes. Let me stay. Maybe we have to. Yes, good morning. Thank you very much to the presenter for a nice topic. Mine is just one. Given the situation right now, GI cancers are on the rise, the incidence is increasing. Now, would you advise the Ministry of Health to start now screening things like colorectal cancers, which are really increasing in numbers?
Thank you very much. Okay, he has broken the ice. Mengine atafuata. Au hatujaele. Okay, karibu. Because it has brought up a very few important, because for addressing anything you have to know the situation. He's set up the situation. Without knowing the situation, hatuwezi kufanya kitu.
Okay, thank you for the good presentation. I'm having a question. We've seen that there is a shifting trend of the incidence of colorectal cancers, and you have mentioned that there is a rise in the young adults. First, I would like to know at what age, or the age group which is considered to be young adults, and maybe from those general risk factors, are there risk factors which mostly affect this young population? Because most of the risk factors, they seem to be accumulating, so that you find the elder ones are more affected. So I want a little bit of clarification concerning the risk, especially for these young adults. Thank you.
Thank you. A third one. Now I'll start remembering my school. When I was a lecturer, I'll start picking you without raising your hand. Okay, Dr. Binde, can you please respond to those? You may respond while sitting, or you can come.
Thank you very much for these nice questions that have been brought forward. So I will start with Dr. Komba, and the question on should we advise the Ministry of Health in terms of screening? I think yes, due to the burden that we've seen and the rise of colorectal cancer as well as esophageal cancer, there have been several studies that have been ongoing And currently along the East African corridor, we have the East African Esophageal Cancer Consortium. Actually, it has done a wonderful job in terms of research, and it's still ongoing. And I think through our platform, our Gastroenterology and Endoscopy Society, we can use it to air it out, and through this will actually help the Ministry of Health through our society to take it for the screening. We know it's kind of expensive. Screening requires colonoscopy and some other tests, fecal occult test. So we need to actually push as a society, as a team, to work together and see how we can mobilize it to the ministry for it to impact in the society. To my brother who has said on the shifting trend, actually there's a shift in the trend of colorectal cancer as well as esophageal cancer from the adults, from the elderly, that has been known for a long time to young adults. And few studies have actually published what has been the cause in this shifting that we've been seeing right now. Some of the studies was saying due to increase in the advanced technology and the screening as well as publication has led to this awareness. But the increase in alcohol, smoking has been, and high body mass index has been seen to be picked so very high on young adult that was not seen before a long time years ago. So that is one of the factor, but yet it requires research to be taken to confirm. Some of the study that have not yet been completed is the tumor biology that is seen in young African differs from the tumor biology that is seen in young Africans, that is young population that is seen in the Western countries. So there's still a gap of research that we need to conduct and find out what are the reasons behind, what are the risk factors, why young people population actually are now suffering from these GI cancers compared to the previous years. Thank you.
Thank you very much. If we don't have any other questions, we might move to the next presentation. Sindio? No. Tuendelea. Vipi? Tuendelea next au tuende 14 next? Okay, so let's move on, and the next presenter will be Dr. Lutfi Abdallah, who is an internal medicine physician specialist at Muhimbili National Hospital and MSc candidate in gastroenterology and hepatology at MUHAS. He has worked at MUHAS and KUHAS, but also had a 3-month stint at Yashoda Hospital in Hyderabad, where he gains hands-on the state-of-art GI endoscopic procedures. And today we'll ask him to carry us through integrating technology in GI healthcare. So he's going to talk about diagnostic advancements, telemedicine, and digital health solutions for better patients' outcome. Karibu sana, Dr. Lutfi. I think this now is working. It's working now.
Good morning, everyone. So thank you for having me, and I'll take you through the AI in healthcare. So what are the current challenges in GI healthcare? So the main issue that we have is the delay of diagnosis, which end up into advancement of the disease, the procedure insufficiencies, and the patient access disparities. So the overview of technological pillars involve the AI diagnostics, the telemedicine, digital health solution, and advancing imaging. So in our case, I'll take you through the EA diagnostics and telemedicine. So what is AI in GI diagnostics? So the main issue that we take into consideration is the neural network component. So AI by itself have been innovated since 1980s, and it have been there, but then the machine learning followed it, and then later on the true brain inside the artificial intelligence happened in 1990s. So what really happens is in every field of medicine, especially with the component of the GI, the data are put in, the AI and the machine learning learn the data. Could be from the image from the endoscopy, could be radiologic images, could be the histopathologic images. And then the machine by itself start to learn the data, does the data analysis into multiple layers inside, and then it can tell you if what you have is what kind of pathology it has, or if the degree of lesions, the grading, and so forth. And these ones are done using a large data. We're talking about thousands of data to feed it so that the machine learn out of it. So in this image, what you can see here is the main component that has revolutionized the AI in the component of medicine is the deep learning component. And with the deep learning component, the day-to-day access that we have is things like the fingerprint scanner, the face ID that we use it on the phone. So the similar thing is adopted in gastroenterology. So with artificial intelligence in gastroenterology, it helps us in many things. Things like obscured visualization of structures. Sometimes you can get in during an endoscopy, and you haven't visualized one part of the GI. Getting to know the identification of the tumors and the depth of the tumors, colon preparations, the quality component of the extubation time during colonoscopy, and the data analysis out of it. So there are multiple roles of AI in quality control in gastroenterology, but then the field that of highest importance is including the GI anatomy, where we can usually divided into either for the upper 8 to 26 parts, reducing the blind spot rate in endoscopy, especially the component of the duodenum with retroflexion at the fundus. The guided biopsy, so that we get the high quality biopsy, identification and characterization of the colorectal lesions, and automated assessment of the bowel preparation using the Boston scoring. So taking it into the real world data that we have, so we have things like Barrett esophagus, where there is mucosal change, where we see through the endoscopy the pale peel is replaced by the pink mucosa from the gastric area. Anything above 1 centimeter from the GE junction is significant. But then when you take a random biopsy, it's very easy to miss the lesions. So we literally rely on the Seattle protocol, where we take the biopsy every 2 centimeters on the four quadrant. But then still with the Seattle protocol, we have 40% chance of missing the lesions. And in that point, we can, it's very easy to miss these plastic lesions. So here comes the AI, where we feed a lot of data inside it, and through the image in white light endoscopy, we can identify the lesion. And in this study, it has found it to be more accurate and superior compared to the human eye. So these are the forest plots in a number of studies, and still it has been seen that it is superior in sensitivity by 0.9 point. And that was statistically significant. Looking at the sensitivity, it has also favored the AI assistance in diagnosing the Barrett esophagus. So the diagnostic odds ratio also showed that this one has favored the use of artificial intelligence in identification of the Barrett's esophagus. But still, with all these data, this one cannot replace a clinician, but rather it guides the clinician, where whenever the lesion is there, then the patient, the clinician have to go and take a look on it and see if that is right or not. And then we have another challenge with the burden of squamous cell carcinoma example in our settings. So unlike the adenocarcinoma and malignancy of the colorectal cancer, squamous cell carcinoma are not easily detected, are not easily seen by eyes, especially when they are early. So the experts can see it very well, unlike the juniors, and this has been seen in almost nearly all studies. So the image at the top, the blue boxes that you see is the one that the AI have seen the mucosal changes in patients which have been confirmed through histopathology that they have a squamous cell carcinoma. And the black boxes at the bottom are the ones that have been detected by the endoscopist. So through the deep neural network learning, it has enhanced the accuracy, specificity, sensitivity, positive predictive value, and negative predictive value. But then in this data, still it has been seen, despite higher sensitivity with the AI, but it is still comparable to the seniors, unlike with the middle level and juniors, junior endoscopists. So when these data were exposed to the endoscopists, and then the test was taken again, it has been shown a significant improvement in detecting the squamous cell, the early squamous cell carcinoma. And this has been seen in all the aspects of sensitivity, specificity, positive predictive value, negative predictive value, and accuracy. So the GI detection of malignancy through the deep learning vis-a-vis the endoscopy, this was done, this study was done in China, where the endoscopists were put in those 3 categories. Everyone was given a laptop with images, and then they were asked to say if the malignancy is there or not, and then the investigator will record the findings. So not only on the aspect of detecting, but rather to say if this, is it invasive or non-invasive? Was it mainly on the mucosa layer or submucosa layer? So what you see on the right side is the magnified band, narrow band imaging, while on the left side is the white light endoscopy. So the A images show the neoplastic lesions, and the B shows non-neoplastic lesion, and all of these were confirmed by histopathology. So after feeding the data, more than 500,000 in machine learning, and compared to the endoscopist, still this one has, the AI, the deep learning system has shown to be superior compared to the endoscopist, both on the expert, the seniors, and the juniors. So there was another issue of artificial intelligence in gastric precancerous lesion. We're talking mainly about the atrophic gastritis, where in endoscopy, those can be seen by looking at the paleness of the mucosa, visibility of the blood vessels, or you can see the atrophy of the gyrus, which is the atrophy of the gastric fold, which are the rugae. But then with an overlap of the H. pylori, all these becomes a precursor for the gastric malignancies. And eradication of H. pylori becomes essential in such patients. So with the meta-analysis that has been seen with the forest and the funnel plot, all these have been shown superiority of using an AI in detecting the precancerous lesion and atrophic and multifocal atrophic gastritis. So looking at the automated diagnostic system for artificial intelligence using endocystoscopy, where the images are magnified, and then we identify the presence of histologic inflammation associated with ulcerative colitis patients. So the image at the top showed the normal mucosa, while the one that you see in the D with the light microscopy, you see there is absence of the visible blood vessel, while at the top you see the visible blood vessel, and we rely on the Mayo classification to assess this colonic mucosa. And the B ones is the endocystoscopy, the C, the histopathology, where we see on the C1 is the normal one, while the D there is a crypt abscess. So all these data are also still fed in thousands and hundreds of thousands, and then compared to the superiority on the endoscopic part. So the computer-assisted diagnosis still also seem to be superior and more accurate compared to the human. But this one, if we look at the Mayo staging 0, which is the normal mucosa, and Mayo 1, where we see there's fainting of the blood vessel to be friable, the sensitivity was quite low in AI. So this is the image showing how the deep learning is done. The top image on the left side shows the normal colonic mucosa. The middle one is Mayo 2, and the bottom one is Mayo 3. So all this one goes through a number of layers of identifying the images after feeding it in multiple times, and then at the end we get the output data. So if we feed the images or under live microscopy, then it can identify if what we have is an inflamed mucosa or the healed mucosa, and it's of what grade. So the computer-aided diagnosis system for ulcerative colitis, it has been shown to be superior to the normal endoscopies among those who have always keeping the images for comparison. And then we have another thing is the capsular endoscopy. So the capsular endoscopy is mainly the pill-like camera where the person can take it in because of the limitation of the upper endoscopy and the lower endoscopy. So with the upper endoscopy, you can go all the way to the duodenum segment, but then from the jejunum, it will be very difficult to reach the other part of the small intestine, all the way to the terminal ileum. All those will be difficult. So when we do a colonoscopy, it's the same. We can do the ileocecal intubation, but then we cannot go much further inside it. So that point is usually we're usually blinded to identify what's there. And it's very important to get to know in these, especially with those with obscured J bleeding, those who are presented with J bleeding, when you have a negative upper endoscopy and lower endoscopy, patients with Crohn's disease and telangiectasias. So there are a number of studies, this meta-analysis assessed a number of studies detecting the application of capsular endoscope in J bleeding, and ulcers, erosion, angiectasias, and others. But then the capsular endoscopy seem to be sensitive and accurate. However, in all studies that have been done in human interpretation for capsular endoscopy, the specificity is high with human diagnosis, but then training someone to go and to be able to interpret capsular endoscopy takes around 6 months. So the utility of AI in such cases is of advantage. So with deep learning and wireless capsular endoscopy, it has been shown to have higher sensitivity and specificity, which is also a bonus on our side. And then we have another thing is with the colonoscopy, we have adenoma detection rate and a polyp detection rate. And these are standardized. According to the quality control, whenever you do an endoscopy, then at least we should achieve the adenoma detection rate of 30%. That means for every 100 patients, at least we should detect 1 polyp. For every 100 patients, we detect polyp in 30 patients. So adenoma detection rate is quite important because this one will allow you to intervene early and prevent malignancies. And with the meta-analysis on the adenoma detection rate, it has been seen that the AI, it favors the AI in adenoma detection rate. At the same time, with the meta-analysis in polyp detection rate, AI have been favored as well. Another component is the telemedicine. So telemedicine is something that came up and it was quite popular during COVID time where we had lockdown. And with telemedicine, the one that has been known is consulting a doctor through video conferencing. But then with adoption of AI in telemedicine, this one have reduced significantly the doctor's consultations on site and decrease in hospitalization and saving the cost. This one helps the patient because it analyzes, patient feeds every concerns and symptoms that they have, and the vitals through the blood pressure monitoring that they have, the height, the weight, what they took in. Some of the inquiries are answered by AI and the patient reflects it to the day-to-day life, and all these have been seen to be advantageous. So in telemedicine applications, there's an educative sessions that are there, both on the live and the recorded ones, which makes the patient to be aware of the diseases that they have, to be well informed. At the same time, the telemedicine reduces the time frame for the doctor to patient consultation time. This is mainly because they have a specific rehearsal component before reaching before accessing the doctor. So unnecessary consultation are usually terminated early. And then we have the digital biomarkers, things like fecal calprotectin, which is done at home, and assessment of the FODMAP, which is the fermentable oligodisaccharides meals. So for the patient with irritable bowel syndrome, whenever they take meal and they get an upset, through the AI they can feed the data, and the AI can usually tell them what have triggered their symptoms. So this one marks the end of my presentation.
Thank you very much, Dr. Lutfi, for, I think what I took home was that AI is there to help clinicians to do their work, is not to replace them. Because sometimes we are worried that AI might take our jobs, but healthcare is a labor intensive, you need a human behind, as he said. But it can help us to improve what we do. Now, any questions? We got some questions from the chat box, but it's not for you, it was for the previous. We'll look at it. Karibuni maswali. Questions, comments, addition? Yes, please.
Thanks very much, Lutfi, for the very nice elaborative presentation. I sometimes work as a biostatistician, so whenever I see data, I'm quite fascinated. Though to the people like Mzee Puge, when the machine learning and AI came, and also disease modeling, it looks like a fictitious of science to them. But really, Lutfi has demonstrated that still AI, machine learning and other upcoming tools are quite relevant in helping and supporting the healthcare industry. So I'm always in a situation that understand, usually in this part of the world, it is usually we fall behind wherever these kind of technologies come, even if some of them have been availed and available for free, but maybe we didn't have the capacity enough of the people with great minds to uptake them and upgrade and customize them for use at our setup. A good example was the COVID-19 era, where Dr. Ferguson and others put up a model which predicted that in Africa and other developing part of the world, it would have been catastrophic. But rather it was contrary, and yet we survived the scourge. We didn't survive, or we didn't avail or prove wrong Dr. Ferguson and others because of the lack of the baseline information or data in the models which Ferguson and others used. By the time they were putting up the models, there was not enough baseline data to do the predictions. And that's why they went wrong. That was an easy mistake they did. So leveraging to the history of the COVID-19 and other platforms, what is the position for the scientists in the East African region in how we can adapt to the emerging technologies, especially AI and machine learning, on solving and helping combating or preventing some of these particular diseases? And for today, gastro is a good example. So mine is the question to you, but rather a wake-up call to scientists and young generations around the region. What is our position on leveraging the upcoming technologies, AI, machine learning, and others, so that we can incorporate it into most part of the sectors, including healthcare sector, and that would help in detection, being diagnostics, but also prediction in managing diseases, especially in the gastro area. So mine was just a wake-up call to the people in-house. Thanks,
Okay.
Moderator.
Thank you very much. So that's a wake-up call and the question for all of us. Karibu, President.
Asante, because it's gastro and many things are really of interest to me. Yes, chairperson showed some kind of fear a little bit in terms of can technology replace us as doctors? Yeah, but I think if you look at it carefully, at one moment it is going to do so. For example, at the moment, there is what we call robotic surgeries. In that case, maybe it is done very fast, very accurately, and maybe we might need less numbers of doctors to operate in the hospitals. So this is actually giving us a challenge and a threat that maybe in the future, the number of doctors needed will be less than what we need now. But on the other hand, currently we are training more doctors than in the past in the presence of technology. So we have to take care of this and give a deep thought about it in terms of what would be the position of doctors in the future as technology is advancing. But now to the presenter, yes, we have presented a number of issues: AI, computer-aided diagnosis system, telemedicine. All these things are now happening in the developed world. But what do you think? What can we incorporate earlier in our national programs? At the moment, I think we should not avoid, we should not shy away from using this technology. But still, I think we are not doing that. Looking at Muhimbili National Hospital, yes, we are using paperless files and things like that, but I think we are not giving enough weight to these technological advancements. So what do you think we can advise our Ministry of Health officials to incorporate in our systems at the moment? AI, you know, it is maybe a little bit far, but can we really do something at the moment so that we can keep pace with what is going?
Asante. Yes. Karibu.
Asante. I just want to add on that. We know that AI models, there are different models we have. And my question is whether do we have enough data where we can integrate those data to integrate AI into clinical diagnosis. I'm saying that because we know, I saw this study, there are 2 or 3 studies which we've done there. So do we have only those studies, or do we have more data which you can give us confidence that whatever we are using, we are sure? We want to avoid the overfitting models. You know, sometimes we have these models and say, okay, this is the perfect one, and we are going to use them. So just want to get it. The secondly, we are in developing countries. We know that the cost of operating, do we have the models which can be fit, can be cost effective, especially in our setting? We know that one of the things which AI can help us, we don't have enough specialists. So that means we might say that this is going to help us in the area where we don't have enough experts. But the cost itself, is it cost effective to use it in our setting? Thank you.
Thank you very much. So, karibu, doctor.
Okay, thank you for nice questions. So starting with Dr. Komba. So with the AI model that usually chosen in every country, the determining factor is the burden. So for example, in our country, we have a burden on GI malignancies, mainly on the esophageal, the squamous cell malignancies. At the same time, we have the colorectal malignancies. So if those note that was said by Dr. Ahmed on screening, that we don't do it. But then when we screen, how much of the early malignancies do we miss? We don't have the benchmark quality indicator on the adenoma detection rate for every clinician. So if I'll be asked what is your adenoma detection rate, I don't have it. And I was supposed to communicate with the patient on my adenoma detection rate if he's doing screening colonoscopy. So we don't have those quality markers. So I think on the component of the government to adopt is strengthening on, I could say 3 things. One, the investment on equipments, having the high definition images, at the same time storing the data and improving on the quality. Those ones will remain to be the baseline prior to adoption of the AI. So coming to Dr. Mohammed's question on the cost effectiveness, I won't really look at the cost in terms of the monetary system, but rather what is the cost if I miss early malignancy? And how will you suffer from it? What will be the cost if someone is having an IBD and I miss it? Just because only small section, segment of the colon is having a lesion that I missed. So the diagnostic cost will increase, and the patient, the disease by itself will advance, which the patient will succumb from. So adopting such an AI, almost every model that we see, majority are FDA approved. And you cannot do any learning model without FDA approval. There are several approval that are usually taken. And the adoption in every manufacturing companies rely on how much accuracy it has, both on the sensitivity, specificity, negative predictive value, and positive predictive value. So those machines are quite expensive, but the government should select centers where they can do screening, and those are the centers that the AI should be adopted, I think, for the start.
Okay, thank you very much. I think we had a good dose of AI and the statistics, but I wanted to, I don't see Dr. Sange. I don't see Dr. Sange here, but our meeting, this symposium has been registered for your, nini zile? Hapana. Yeah. So this symposium has been we are awarded 4 CPD points for attending, and this is for the medical from the doctors. I think we have not been able to do that for the nurses and the rest. Sindio? Yeah. Yeah. Okay. So we will break here for 15 minutes to have our tea very quickly and come back for a panel discussion, because I think the president has other commitments, so he's part of the panel. So we have the panel discussion and then continue with the other presentations and our sponsors' presentation after that. So let's go for tea, Cindy. Yeah, where can they have the tea? Okay.
So thanks very much, the moderator, and also all those who have been taking sessions in this first round. And as for the CPD points, putting it clearer is that we were awarded 4 points, as Dr. Ipuge said. We deeply apologize to other cadres, as we are not yet approved by the relevant bodies, the next bodies, also the Farmers Council. We are on the way. Maybe in our upcoming programs, we'll be able to cater for most of the cadres. But as for now, the medical doctors will have a register at the door of entrance. So you'll have to register your name there and perhaps the MCT number, so that we can submit your information to the board, to the council, so that you can be awarded those 4 points. And for the tea break, just the door which you used to come in, if you go out on the left, there are some tents outside there. So let's have a quick snacks and a cup of tea or coffee, and then come back and continue with this particular event. With that, we thank you very much for your attention for this particular time. Thank you very much. We'll be back at 11:25. Thank you.
Following, you move forward and take your seat. The next one is Dr. Tausi Maftaha. Dr. Tausi Maftaha is a specialist in molecular imaging and technologies, which is nuclear medicine imaging. She's the only female in nuclear medicine clinical practice in the country. She plays a significant role and serves as the IEAA country coordinator, with roles of establishing, expanding, and fostering sustainability of nuclear medicine services in Africa. So she will be with us on the panel. Then we have Dr. Sikuzani Muya. She's a consultant clinical and radiology oncologist, a lecturer and a researcher at Ocean Road Cancer Institute and Muhimbili University of Health and Allied Sciences. I would also like to invite Dr. Serafini Mroso. Dr. Serafini Mroso He's a medical specialist at Muhimbili National Hospital, specializing in gastroenterology and hepatology. He has 14 years of experience in clinical practice. He's now doing his Master of Science in Medical Gastroenterology at MUHAS. Then we have Dr. Anton Okanit. Dr. Anton Okanit, from our colleague from Uganda. He's an internal medicine physician at Kirundu National Hospital in Uganda. He's specializing in gastroenterology, and he has a postgraduate diploma in gastroenterology at the University of South Wales in the UK, and so that has solidified his commitment in gastroenterology and digestive health. So those are our panelists for today, and so I'd like to start with when you have a president, you start with the president, okay? So Dr. Eduardo Komba, would like you to take us through on what you think are the policy implications of gastroenterology and digestive diseases in East Africa.
Thank you very much for this first kind introduction and giving me the first chance to speak before all of the other speakers. That will give me an opportunity to say quite a lot without repeating somebody's messages. Yes, as we said earlier, gastrointestinal disorders are quite prevalent. There are so many, and most of them would actually impair the quality of life of those who have them, and definitely this will have some cost implication. So that is the economic burden to the patients. Now, among the policymakers, I think there are many issues that they should look at, and I will discuss maybe 4 of them. One is in policy making, we should look at the public health and prevention issues. By this I mean one of the things that we can do is first to promote health eating or health habits. For example, there are conditions that are caused by a person's decision by deliberately taking something into excess. For example, liver cirrhosis. Many people would suffer from liver cirrhosis by excessive consumption of alcohol. So in public health teaching, we should advise people on the negative effects of alcohol and what would be the safe limits of taking alcohol. We know they cannot stop, but they can take safe amounts. But at the same time, there is one crucial issue in prevention and public health, that is screening and early detection of diseases. I think until now in Tanzania, I don't think if we have a very good screening program for any disease. Maybe recently people are advocating screening of maybe cervical cancer among women, screening for hepatitis B infection, but there is no concrete running program on screening issues regarding diseases including cancers. So one of the areas that I think we should focus on is on screening, and by screening we can detect early diseases which are potentially curable, particularly the cancers. But there are other things which are easy to do. For example, promoting hygiene, okay, and food safety. H. pylori is quite an important cause of gastric cancer. And the acquisition of H. pylori is through eating contaminated food, transmission from human feces to the next person, you get H. pylori, and you end up getting cancer at one point in time. Recently, my postgraduate student has done a research on gastric cancer, and the majority of patients who have gastric cancer have H. pylori infection, actually underscoring the effect of H. pylori on cancer formation. So simple hygiene and eating habits could prevent such cancers. So that is on the side of public health. But then coming to the government itself, there we need some issues to be settled. One of the major issues in gastroenterology is the cost of services. You go to any hospital, ask for the price of doing HAPA endoscopy, OGD. If you get a low price, 250,000 T shillings, 400,000 2 shillings, Tanzanian shillings, it's very expensive. So now how can the government make equitable access to health services? How many gastroenterologists do we have in Tanzania, and what is the cost to see them? You go to many hospitals, you want to see a gastroenterologist or super specialist, it's not less than 30 to 50,000 T shillings. So how many Tanzanians can afford? So now this is on the side of the government to make sure that health care is accessible to all Tanzanians. The other thing that I think I should discuss on the policy implications is about the societal impact of these diseases. One, as I've said, economic cost. It will really enormously increase the cost of a person who is actually suffering from a disease that is related to the GI. I was just chatting with some doctors at Ocean Road, and one of the patients needed this, what we call targeted therapy, bevacizumab. The cost of it, one injection, is 6 million T shillings, and the patient would need 6 injections. That is 30M. In this room, who can afford 30M for one injection? Leave alone other treatments that are given in combination. So you can imagine the cost burden that can actually be faced by this patient. So that is another area in policy making. How can we actually improve the cost of treating patients? But apart from that, there are issues related to quality of life and psychosocial well-being. All diseases would actually, at the end of the day, impair these aspects. So how are we prepared as a nation, for example, in handling such issues, the psychosocial issues? The quality of life is low. How can we bring this patient back to the normal state? But the other thing in policy making would be now, this is quite often forgotten, the issues of research and innovation. I belong to the academic institution as a lecturer at MUHAS. Research, of course, has been one of the major issues that we should do. It's a requirement, of course, for promotion. It's a requirement among our students for completing their studies, MMed students. But that is not the most important thing. The most important thing is to do research on various GI conditions, get evidence-based information on the best care that can be given, and then translate this information into practice so that doctors can apply. And some of this research can actually invent something which is maybe more cost-effective and cheap. And of course, when it causes cure to a disease which was very expensive to treat, that would be something very good. But now, how is the government prepared to support research? Up to the moment, I think very few funds are actually released by the government to support research. If you plan a research that would cost 10 million for an MMed student, they will most likely not get that amount. They will get maybe 2 million. But now with the 2 million, how can you make a very nice research and come up with the findings that will help Tanzanians. That is a big issue. So maybe to start with, these are my few remarks.
Thank you very much, Dr. Eduardo, for that, and you've covered, as you said, you are very, you say. So, Dr. Skuzani Muya, Dr. Eduardo has mentioned about some of the public health issues. So, what do you think are the key public health aspects of GI disease, and especially malignant diseases? Karibu.
Hi. Okay. Oh, thank you. I think Dr. Kuma has pinpointed and highlighted most of the things that we face. Speaking of malignancy, as in I'm in the tertiary hospital, so I would think the most important part is the high emphasis on high suspicious index that this could be malignant, that need to be implicated in the very low health sector areas, as in dispensary, because that's where most of the patient goes. Like if a patient comes, most times the patient will go very early complaining of heartburn or constipation, parectal bleeding, but most of the healthy workers, maybe due to, depending on our referral system, like in the dispensary or district hospital, you don't find most of the specialists that side. So they start with the antibiotics, the PPI and everything for sometimes up to 3 years. And if that is cancer, it means by the time they come to be referred to the high centers, that is like if it was stage 1, then that is like almost 3 to 4 with metastasis. So the main emphasis is the education to the health workers, because they're the ones who see the patient in the first place. And then improvement of the diagnostic procedures, like in the district or regional hospitals. The simple test that can be done there should be done on that side. So that when we're talking about tertiary prevention, that's treatment, at least we should be able to get this patient at a very early stages. I think that's, in summary, that's what I can say on malignancy.
Thank you very much, Dr. Muya, for that. Dr. Serafin Mroso, what disease prevention strategies should be prioritized in GI diseases?
Thank you, Chair. So regarding the strategies for disease prevention, GI disease prevention, we need to advocate that, because we need to prevent the disease primarily, but also early detection, so that you can prevent the morbidity and mortality. So there are so many strategies that we can deploy to prevent these GI diseases, ranging from the diet. We have seen some diet and the lifestyle is highly attributed to the GI diseases. We have seen diseases like metabolically associated dysfunctions. Diabetic liver disease is highly associated with metabolic syndrome. High fat diet, the Western life, but also some diseases like colorectal CA, that is highly associated with taking red meat with low fiber diet. So we need to advocate the use of high fiber diet, for example, that can prevent diseases like diverticulosis, but not only prevention, but also treatment. But also we need to advocate on infection prevention. The strategies are ranging from vaccinations. We have seen significant diseases that can be prevented by vaccine. We have a very strong vaccine for hepatitis B, for example. We have seen more than 70% of patients with liver cirrhosis in our setting is attributed to chronic hepatitis B. So vaccination is a very good strategy. But also we can treat all those who have already contracted the disease, and this ranges also for hepatitis C. We have very good drugs for hepatitis C, but also for other infections. The chairperson of TAGIC and Dr. Ahmed took us through the gastric adenocarcinoma, in which it is highly attributed to H. pylori. It is #1, class 1 carcinogen. So having the strategies for prevention of H. pylori, as was mentioned by our chairperson, that can help to prevent not only the tumors of the gastric adenocarcinoma, but also other H. pylori related GI infections ranging from gastritis, peptic ulcer, etc. But also we need to do early detection of some GI conditions, things like Barrett esophagus. So we have to make sure that all patients with GERD, symptoms of GERD, they are followed, because they are at risk of getting Barrett esophagus, and we know that when we identify it early, it's treatable. But also, Dr. Ahmed took us through the colorectal cancer. He mentioned that nowadays there's a trend. We see, it was not normal in the past, but nowadays the trend has changed. We see patients with colorectal cancer at young age. So probably we need to do our study and see what is, but majority they are attributed to familial adenomatous polyposis. So we need to do, when we encounter those patients with multiple polyps in the colon, we need to do, and with that family history, because it is autosomal dominant, so we need to do genetic screening to the family, because it has a 100% lifetime risk of developing colorectal cancer. So, and many times you can, it is advocated to do early screening, even at the age of 16 years, unlike the general population, of which it is advised to do screening colonoscope at probably the age from 45 and 50s. Yeah, so these are some of the strategies. When we play them together, we can prevent this GI condition, without forgetting also the secondary and tertiary prevention. There are so many patients with already said GI condition, liver cirrhosis. We need to do an early screening, for example, to prevent hepatocellular carcinoma, like surveillance for HCC every 6 months, in which you should do alpha-fetoprotein as an ultrasound, which is very good sensitivity. But also we need to screen for other complications like varices, in which you need to do appendoscopy yearly to prevent those complications. Thank you.
Thank you very much. So we have looked at the disease, the prevention, policy implication. Now the person has disease, we have to treat and manage. Dr. Tausi Mafta, can you take us on approaches for treatment and management of GI diseases?
Thank you for this opportunity. Yeah, for the management, of course, of these diseases, sure, cancer management is expensive, as everyone, of course, the president here has mentioned.
Once the diagnosis is made, the journey of management is expensive, from surgery, chemotherapy, immunotherapy, investigations. All these are very costly. But of course, need to be done. And before you manage this patient, you need to know the extent of the disease. Knowing the extent, need several investigations to be done. I'll just advise broadly on the government to make sure the availability first of these diagnostic imaging services, at least each zonal or tertiary hospitals, so that when we do the staging early, we understand that cancer can be cured when diagnosed early, and of course staged at a very early stage. So when we talk on gastroenterology, of course from the esophagus to the anus, there are a lot vast of therapeutic agents used, chemotherapy from the first lines to third lines, but speaking to the very advanced modalities of management, we have the immunotherapy and nuclear therapy, which of course some are not available yet in our country. For example, when you speak to gastroenteropancreatic cancers, you need lutetium therapies, which of course these somatostatin analogs, they are not available, and we just need to make them available, and of course involve also to have this private and public partnership to make these services available, and training of personnel to make the experts available locally, so that when you sit, because in management of cancer you need tumor board, you need a multidisciplinary team for the, of course, gastroenterologist, surgeon, nuclear physician, oncologist, radiologist, everyone to be on board. So these need to be trained in these advanced modalities of therapy, so that you know when at what point in time this tumor is refractory, this tumor environment is like this. So all those need to be understood, and you speak one language to know the behavior of the tumor, and you treat accordingly. You say now the advancement is personalized medicine. You can have the same tumor with a different biology. And it's not that you use one mode of therapy for the same tumor. You can have even 3 modalities for one tumor, depending on the behavior of the cells at each point in time. So this needs to be understood, and at least when the experts understand, they know at what point in time which modality to be taken, which investigation to be done. So the government, just to help this to be available, because sending patients outside Tanzania is very costly. These people are sick, they need relatives to escort them, they need accommodation where they go. The kind of President here spoke about, of course, lifestyle and diet. Our lifestyle diet is different from abroad. You are sick, you can't get the food you want. So being at home as a cancer patient is very favorable even for the prognosis. So management need to be done locally, and at least we understand our geographical behavior, and it is very easy because Counseling also is a part of management in cancer patient. We need also, because it's a holistic approach, we need to take in all aspects in management of cancer. So understanding also these geographical and tribal issues locally is very easy than going outside Tanzania, which nobody can understand. Wewe ni umetoka Pemba, umetoka Songea, or something like that. At least the approach in taking care, which medication at least to counsel the patient is very easy to be done locally. Yeah, so they have touched the issue of research. It's a very important aspect because without research, you won't be sure of the direction of response of therapy response to those kind of cancers you are dealing with, your community, what make maybe maybe gastric cancer or pancreatic cancer or hepatocellular carcinomas. Why are they common in certain area? So why are they, maybe you are giving this immunotherapy or chemotherapy is refractory? So those are issues which you need to bring on board to understand our issues locally, so that when we manage this patient, we know also direction, because we sometimes we just hit on the bush. You don't know the behavior exactly, who is not responding and why, so that we can also advise the private sectors and the government to make sure these things are successful. Yeah, thank you.
Thank you very much, Dr. Maftah. Now, this is an East African symposium, and we'll also look at regional issues. So, Dr. Anthony Okanit, can you enlighten us what you think are important regional frameworks that should be developed for better health care of GI disease in East Africa? Karibu.
Yes, thank you very much, moderator, and thank you for welcoming me to Tanzania. Hope next time I come and I can be able to interact in good Kiswahili. Yeah, so I'm going to, I've been given this opportunity. I'm going to actually concentrate on the gist of the first presentation. The first presentation actually concentrated more on the global burden of disease, where we are, and I'm going to talk about actually sub-Saharan Africa. And it was found out that actually that the most common problem we have here were mainly two. One was enteric infections, and the other one was chronic liver diseases. Chronic liver disease, and of course where we have cirrhosis there. And of course also not forgetting cancers of the GIT. Yeah, so let's go back to enteric infections. This is the 21st century, and we're talking about actually diarrhea. It was common, it's mainly common in the pediatrics, but we have it also in adults. Yeah, so we're wondering what is happening. What can we do what can we do more to prevent those diarrheal infections in this 21st century? So we are talking about regional frameworks. We actually have isolated frameworks, or rather isolated organizations or programs which are being run independently in different regions, or rather in different countries. Yeah, and I may not name them, but they're actually very many. Some of them are concentrating actually more earlier on hand washing and hygiene, and then access to clean and drinking water. I don't know whether we still have them very active, but I think the best way to go would be actually to encourage regional collaboration between these frameworks, these different organizations. And actually, when you have those regional collaborations, we're able to appraise each of these different organizations. I can talk about the East African Community Health Regional Framework. We also, I think, have AMREF there, and many others. And when you have those collaborations, I hope we'll be able to eliminate this or reduce these enteric infections. The other thing, before I move away from the enteric infections, is still the H. pylori. That has been talked about a lot. Yeah, so I'll refer back to where I practice from. Yeah, we have a lot of empiric treatment on H. pylori. Doctor, I have stomach pain. Screen for H. pylori. Start on what? Empiric treatment if the antibody is positive. So we have unregulated use of these drugs, and then also we don't have standardized ways of screening for H. pylori. So if we are able to actually come up with algorithms that can guide us on how to treat, diagnose and treat H. pylori, this we could actually use to inform the role of non-physicians or the rural clinicians, yeah, which are not actually specialists, which could actually help us to prevent these complications. One of the non-communicable diseases that we are at risk of, which is actually on the rise currently, is the GI cancers that has been talked about. So gastric malignancy is on the rise. So if we are able to mitigate this H. pylori well, come up with our guidelines and inform others, I think that would be actually of good importance to digestive health. Secondly, to the non-communicable diseases, the leading cause previously, in the recent past, has actually been, when we concentrate on chronic liver diseases, alcohol and viral infections in the low and middle income countries. Those are the common, that's what the common causes. And we used to ascribe the other causes of chronic liver diseases to the Western world. That is diabetes and obesity. But of recent, in the current actually study of the global burden of disease, we realize that we're actually having it also on the rise here in our region, in the low and middle income countries. So how can we go about this? First of all, of course, we'd go to informing the society or the communities. What is the risk? As has been talked about by the chairman. What is the risk of alcohol? And what is its impact on disease and health, or on our health? That is one. And of course also, we need to inform everyone, including the clinicians and the community on the preventable infections that give us chronic diseases, chronic liver disease, hepatitis B, hepatitis C, and the rest. I'm happy that we have actually a global guideline on management of hepatitis, but we have not adopted it so much locally here. I don't know how, or rather we have not actually found a way of rolling it out today to our facilities, because still I get a lot of referrals, poorly managed patients who have hepatitis B. So this patient has been deceived that they are going to cure. For the last 5, 7 years, 10 years, ever since they diagnose the infection, by the time they come to you, they already have the complications, chronic liver disease. So how can we go about that? Informing the public, yeah, that can help us to prevent. So if we could also find a way of rolling out these guidelines that have been actually developed by the WHO, yeah, I think could be able to help us mitigate that. Yeah, and of course, the other thing is on the diagnostics, really. Let me concentrate also on the diagnostics in management of digestive diseases. Endoscopy actually plays a key role in diagnosing and management of liver diseases. But one of the recent studies that has been conducted actually here in sub-Saharan Africa shows that we have a very low uptake of endoscopy and utilization. That is both upper and lower. Yeah. Meaning that we're actually missing out a lot of these patients early. We are not they're coming to us when they already have the carcinomas. So if you're able to capture them early by enhancing the capacity of endoscopy and actually improving the endoscopy services. I'm happy today we talked about also integration of technology and AI into what? Into the diagnosis of GI disease. Yeah, so hopefully we should be able also to diagnose these patients early. Leave alone that we have very few specialists around the globe in GI, and if you come down here, I'm very sure even Tanzania, the president will tell us a handful, I'm very sure. If you go to Uganda, I can count all of them, I know all of them. all the GI specialists, the GI physicians. So, can we do task shifting in this case? Is it possible? And this has been done as a pilot in some of the countries in Africa. Task shifting. So what do I mean by this? So, we have a few specialists. Can you empower others, build capacity? Let's train those GI nurses you work with. Let's train the other clinicians who are involved in care of you in how to use these endoscopy services, how to diagnose, and how to also do the therapy. So, but of course, the key thing is diagnosis, even though they may not do the therapy. So this has been done in some places. I think there's a study from Malawi where that has been done. I think it was supported by the Belgians, and then those people were taken for, non-GI specialists were taken for training. They came for some period of time, came back later, and then they were followed subsequently. Their utility of the endoscopy and then their diagnosis, actually they were scored. And it was actually from good results, as we had, not as we had anticipated. So, capacity building, training others, that is what I would actually go on. And then the last thing, which has already been mentioned, is actually research in digestive health. Let's strengthen research. I'm happy I'm a beneficiary of research. In the end, I did my med actually with self-sponsorship. But in the end, I got a sponsorship because of the research that I did. Someone was interested and said, let me facilitate you, continue with the research. So let's strengthen and support research. Research will not only inform policy, but will also be for advocacy and also attract funding to the digestive health care. So if you concentrate your research on digestive health, then you attract funding which can be able to give us the funds to buy the things we are talking about. Now when we're talking about integration of digital health, we switched off. I'm very sure I'm not the only one who switched off. But we're thinking of where shall we get that money? Well, it comes actually from the research. Thank you. I think I'll first stop there for now.
Thank you very much. Please put together your hands for our panelists. They've done a wonderful job. I was taking notes. I just remembered my first year in medical school when I was learning new things. You have taught me a lot. I think, thank you very much. So, if you're excited like me, I want to invite you now to participate in this discussion. At the end, I'll give them 1 minute each to wrap up. But now, I would like to invite you all to join the discussion by contributing. You can contribute in any order. You can also ask questions, but I would like more. Let's engage in discussion. Secretary General, do you have someone taking notes, or is it being recorded? Okay, thank you. Karibuni, please. I want to see hands. Dr. Mohammed, I will ask you to say something on regional frameworks as well. We didn't have enough space on the panel, so be prepared. Please come in. Yes, thank you.
Ladies and gentlemen, habari. Yes, my name is Leo from the industry. And I have a question for our president of the GI Society. I think I'm with Dr. Anthony. Since the improvement of the awareness about H. pylori risks and even other digestive disease risks is very important. So as the GI Society, Dr. Kaba, do you have any plan to work on like a guideline for the management of H. pylori? Thank you.
Thank you. Thank you very much for breaking the ice. Someone to slide on it. Yes.
Hello. Good morning, everyone. I'm Dr. Ferdinand. I'm a fellow, surgical gastroenterology and hepatology. The first presenter, Dr. Komba, talked something about advocacy on trying to the society on trying to prevent these risk factors, which in the first place causes all these GI problems. Now, regarding the environmental risk factors, like the things that the population is consuming, like foods, drinks, like alcohol, and our efforts on trying to provide awareness to the population on how to prevent themselves from such risk factors. I can see there is a bit of a conflict of interest, especially with industries which contribute to the economy of our country, like these big companies, maybe Coca-Cola companies or companies for beers and stuff. Of those alcohol drinks, if the population consume them, they contribute much to the obesity, and that becomes a risk factor for these malignancies, especially the gastric CAs and esophageal CAs. So as the GI Society, the TEAGIC, the TAGES, how do we address this conflict of interest? If we go out there as doctors saying people should not smoke cigarettes, people should not drink beers and take alcohol, people should not take Coca-Cola, don't you think we are going to face a backlash? So that's a dilemma I want Dr. Komba to address. Another issue is we have seen a lot of societies, for example, in the modern world, and they're using the social media, the YouTube, the X, the Facebook, the Instagram, to raise awareness. And currently we have the famous Professor Janabi trying to raise awareness about the non-communicable disease like hypertension. So the GI Society in Tanzania, are we having such programs like using the social media? Are we having our own YouTube channel so that we can address these risk factors? And because now we're in the blink of social media, everybody is pushing the agenda through the social media, and it's becoming very powerful and very easy to raise awareness. So are we doing any efforts at GI Society in Tanzania? And the second speaker talked about things about management of especially people coming very late at the tertiary hospital, and she was emphasizing something about we should enable the hospitals down the referral system, maybe at the dispensary level, to have high index of suspicion and pick these lesions early so that we can have good outcomes. So recently we have endoscopic tests as the an important test in picking these lesions, especially H. pylori, which have complications with upper GI bleeding and a risk of malignancy. But at the dispensary level, we don't have experts. And I know one of the qualifications, the minimum qualifications for someone for a clinician to do an endoscope should be a super specialist. And we have very few super specialists in Tanzania. So do you think we can run this marathon having a policy that only super specialists should are the ones to perform the endoscopy? Maybe the second speaker can speak about that. Maybe Dr. Komba also can chip in on that. What is the minimum qualification for a clinician to perform a recognizable endoscope. And then with respect to efforts in the prevention and treatment of GI condition, maybe the last speaker from Uganda, and maybe Dr. Tausi, is there any regional, any platform at regional level that we are collaborating maybe with Uganda, Kenya, maybe Rwanda, Burundi, South Sudan, that will address this GI, especially in the rise of hepatitis and liver diseases? Is there any regional efforts that are available? Because I think in the East Africa we are facing the same issues, and almost ethnically we are almost sharing some entities. And lastly, regarding the treatment of advanced malignancy at Ocean Road, at molecular medicine, Dr. Tausi mentioned about having a tumor board with experts that are supposed to be very well trained. So currently, what is the situation? Are we having any liver tumor board, any tumor board available? And are we utilizing it? And what are the challenges? And maybe what should be done to make sophisticated treatment available in Tanzania? Thank you.
Thank you very much. You are very clever question for everyone on the panel. Okay, there's a hand there. When I see a lady, I cancel men. Then we'll come to your side.
Thank you. This is a question to the whole panel. With growing evidence linking mental health to gut health, especially amongst the youth, are hospitals and clinics treating chronic GI disorders with an integrated approach to psychological care? Are there any plans or practices of that form?
Thanks very much, our panelists, for the elaborative explanations. Mine yet is not a question, or rather a thinking, and maybe I want to share with others as well. Taking to the traced by Dr. Komba, who also was pointed by Anthony, research, whereby we could be able to generate data and information that will allow the practices, but also the trends of disease as well. Looking at the current situation that we decline in funding landscape globally across various disciplines, and that would have been posing another challenge, as if we can't have money for research, that means we won't be to generate more data, more relevant. So with that, what could be an approach to take? As we know, most of our governments across the developing world contribute little in terms of building capacity in research. So as scientists and experts, maybe what would have been the way out from this particular situation? That's one. Two, linking it to what has been presented by my brother Lutfi earlier on the upcoming of the new technologies, especially the machine learning and artificial intelligence. As someone also put it earlier on, that we have a lot of data we are collecting of patients on daily basis. How could we utilize or make use of the information of patients collected on daily basis as baseline information that can be used to integrate into the new technologies that can be used to help inform trends of diseases, by using the new technologies. Because if we can't have funds for research, what I know in the daily routine practices, we are generating a lot of data. So anyone in the room or the panelists can help on two things. How do we leverage the ongoing funding landscape going down, which hampers the doing research or clinical, generating clinical evidence data, and how we can use the new platforms available using the routine collected data, trying to inform the trends of disease, but also new interventions that can be generated from the data. Thanks.
I see a hand there.
Yes, good afternoon, everyone. My name is Shaban. I'm a resident in clinical oncology. I think my question will be addressed to Dr. Komba and Dr. Muya. They have spoken a bit about capacity building in the lower cadres and the junior in the lower healthcare system. And I just want to ask if a thought has come or an effort has been made to strengthen in the training of these lower cadres in regard to non-communicable disease. I remember my exposure during undergraduate in the, for instance, cancer care. We just had a one-day visit to Ocean Road, and this is the practice, I think, till now. So I want to ask if there has been effort to review that and at least add an exposure to medical students so that they have a bit of understanding of these non-communicable diseases that has come to top now as compared to communicable disease. And the other is maybe to enhance the training in regard to non-communicable disease. Thank you.
Thank you very much. So I think we have good input from the floor, and every one of you have something to respond. So I wanted the president to be the last in the response, but due to other commitment, I would like him to start, and then we'll allow him to leave if one is done, and maybe he'll leave someone for us to take his place. Karibu. Una mwanachama mwingine wa society hapa?
Wapo wengi.
Wapo wengi, sawa.
Hata Serafini huyu hapo. Mbroso.
Okay. No, anaanza president.
Thank you very much. I can see a number of questions have been directed to me. I would start from the representative of RIMA. I forgot your name, I'm sorry. But it was a very crucial question on the guideline issues. And we have said many times H. pylori is quite prevalent in our place. So do we really have a guideline? We have the national guidelines of management of diseases. And in Tanzania, it's actually one book with a lot of diseases, and many times it is being updated. And in that guideline, it has been stipulated very well how should we diagnose H. pylori, and the emphasis at the moment is on the use of non-invasive tests, and of course, preferably. We are using a stool antigen test, and we are actually advocating on the use of the urea breath test, and in very special situations you can use the serum testing, which is, of course, we know it cannot inform you about the active infection. And the management, of course, yes, we have. But the major problem is, yes, we follow the guidelines, use the triple therapy, then quadruple therapy, and then you can have the rescue therapies. But we don't have the local sensitivity data on the bacteria itself, but at least recently one study was done to look at it, and we have seen some antibiotics which are really
sensitive to the bacterium, but we really need more research on the sensitivity of the H. pylori infection to the antibiotics, and then we can actually formulate a localized guideline on the management on which medicines should be started as first line. So at least we have the guideline. The second one, this one is tricky. It involves the economy, it involves the health from one of the members regarding the conflict of interest of some of the risk factors on GI disorders, and the alcohol was specifically mentioned. And of course, I don't know if you mentioned also about cigarette smoking, which is another risk for the GI cancers. There's a really very big debate on what should we do. But always knowing that there is an attached risk on the use of those products, then all these manufacturers have been by law informed that you have to state that if you take this, it is hazardous. So an individual is well informed about the risk of using that product. That is one way of educating you. And if you are aware that this thing is hazardous and you still take it, then we have to ask yourself, are you serious with your own life? And you have seen people suffering from complications of using that one. It's the same way as transmission of HIV. You know, unprotected sex, you can acquire HIV, and still people are getting HIV every day. Now the question is, what else can we do? So as the society, we'll keep on educating people on the risks of these products like alcohol and cigarettes, but at the end of the day, it is the individual to make a good decision how they can now further prevent the infections. The other question was on, this is quite crucial, as targets, how do we really take up the social media in actually educating the society on the GI issues? I should admit that maybe we have not done a lot in that aspect. At least we have a web page, interactive web page of targets, and maybe main things which have been posted there, it includes some of the maybe the meeting issues and things like that. But in terms of educating the society on issues regarding prevention or management or diagnosis of the GI issues, I think that area has to be strengthened. And I'm sure my colleagues are here and they are members of the society. We have to take this as a challenge. And in the future, at least we should show that the social media can be used very well to transmit information on GI disorders and their management. I would just go to one of the questions which was partially directed to me and partially to another speaker in terms of who should do endoscopy in Tanzania. There are requirements that a super specialist should be doing endoscopy. I don't think if that requirement is from targets or is from the government as such. I think it is particularly related to what you call the insurance companies. And what is the interest on that? I know they want to see that someone is well qualified. At the moment, the insurance companies would recognize the fully trained gastroenterologist. And remember, an endoscopist is not a gastroenterologist. And an endoscopist would just do endoscopy and make a diagnosis based on that. But a gastroenterologist would actually do more than that in terms of management of GI diseases. I would support the concept of having short courses for training the endoscopists on properly doing the endoscopies. I remember one professor used to say, we have endoscopy pushers and we have endoscopists. He made a very strong point. It's not just a matter of pushing the scope into somebody's esophagus or stomach. You have to know, how should I detect the lesions? How should I interpret the lesions? How should we properly conduct endoscopy? One of the key issues, how do we prevent infection transmission from the patient to yourself? And how should I manage, of course, the endoscopy suite, and how should I design it? There are a lot of issues. So to do that, we need short courses for training endoscopists and who should be certified. But now, do we have any in Tanzania? We don't. So maybe the major issue, we should now look forward to establishing short courses for that, and the persons or the doctors who will be trained will be limited to the diagnostics and refer patients for interventions to the gastroenterologists who are better trained. So in that case, in that way, we can pick up early cancers in the GI, and we can manage our patients better. So that is, I think, what I could answer on that aspect. In terms of research, how can we maximize what we have and conduct very, very good research so that we can innovate some things and we can help our patients better? Oh, I think in research, sometimes there is no shortcut. We need investment. We need investment. Go to America, there is a lot of money directed to research. Go to the companies, they have a lot of money directed to research regarding either the diagnostics or the therapeutics. But when we have the limited amount of funds, we cannot say we are going to sleep. And that's why at the moment you go to any university, MD students have to conduct research. This is a necessary component of their finishing that kind of training. So we should try to design a research that can actually utilize the little funds that we have. But at the same time, the one who asked the question mentioned, we have data which is collected on daily basis on our patients. You go to the ward, a lot of investigations are done, and patients are paying by themselves. So we have an archive of data in the records, and these days, thanks God, we have these record in soft copies. So in that case, it's very easy to use those records to design a research retrospectively and come up with some data. But the major issue, and most of us here are doctors and medical personnel, how quality that data is. Usually it's of very poor quality, and there are a lot of missing information. And when you want to conduct a retrospective study, you'll be having a lot of missing data. In that case, you cannot get that very good answer that you intend to get in your research. So let us improve. The clinicians should improve in terms of recording patients' information. And that would be key in the future in getting actually data that can be part of the research and answer a lot of questions. Yeah. The other question was now in terms of capacity building of the lower cadres. Okay? Yeah, thanks God. If you look at the output of doctors in Tanzania right now, is quite high. Every year, not less than 1,000 MDs graduate, okay, at the level of MD. And at the same time, many universities now actually have established a lot of training programs, including the highly specialized training programs. I think I would say this time is not the Nyerere period. It's the time when people should actually force themselves to go back to school. Go and do your specialization. If you come to MUHAS, when we do the selection of postgraduates, we first look at who is coming from the over-the-country regions, from Rukwa, from Songea, from Twara. These are the people whom are given priority. Just come to school and increase your level of education. But at the same time, we have established these short course training programs. Last week, I was invited to close training on echocardiography, just echocardiography, because we know there is a lot of rheumatic heart disease in the country, so we want people to pick them from up the country. So these short course programs are also established to empower and actually to build capacity in terms of diagnosing these conditions. So when we see one condition is highly prevalent, then it's high time to establish the short courses programs, and MUAS, as one of the universities in Tanzania, is actually keen on that by preparing these short courses. So I think at the moment this is all what I have. If someone is still has not got the answer that they asked for, please, you can just remind me. Otherwise, I should allow the next speaker to respond to the questions.
Thank you very much, Mr. President, and feel free to be able to walk out when you think the time is there. But if you stay with us, we are more happy.
I will leave other questions to Dr. Amroso and Dr. Lutfi, please.
I know, and also the other panelists as they are responding, then we'll see if the answers are not captured. Yeah.
Okay.
So, okay.
That's it.
Okay. Dr. Amroso.
Thank you, Chairman. There was another question from doctor regarding seeing many patients with psychological problem presenting with GI component. Yes, there is a strong association between the psychological, including stress, depression, with GI condition, much of which when there is we call gut-brain axis, so when it is disrupted, together with other factors like changing microbiota and so many others, all together they can bring up the GI symptoms, like in IBS. So you only find you look for all the risk factors, for example, those with diarrhea, predominant constipation, predominant IBS. You cannot find one, but when you expose this patient to serotonin antagonist as one of antidepressant, you find out the patient is improving. So there is a strong relationship between psychological disorder, stress, with GI condition. Yeah.
Hi, hello. I'm going to respond on the Dr. Freddy. You were talking about, you were asking on high index of suspicion, okay? And I think on the part of who should do the endoscopy has been done, okay? So, you see, having high index of suspicion is the first step of sending the patient to the higher level. So it doesn't matter in where you are if you are able to access the investigation or not. Like we had a sort of training which was sponsored by the British Council and Bank of Africa. So what was the training was about is on the cancer is on the rise in the region. That was mainly on the East Africa. So what we did is the academician in the oncology part. So we had like a different setup of meeting, as in a conference, training to the attending physicians. These include medical officers and clinical officers. And the training was involving the different types of cancer. So there was like a presentation with different pictures from adult to pediatric. So if you are in the clinic, a patient comes with a complaint of a headache, because the first thing that comes to your mind is a clinician in the dispensary or health center. The first thing you think is a headache, this may be malaria, okay? But then this patient you've treated like consecutively, a month, which type of malaria that doesn't respond? In a month, this patient always come complaining of a headache. So now it's like, so if you see a patient with headache, you've treated with whatever that you think, maybe this is malaria or whatever that you think, and then still the symptoms persist, you have to think this could be something else. And this something else, can it be cancer? Then if you think on that line, whether it's a GI malignancy or brain tumor or gynecological malignancy, especially cervical cancer, this patient comes to you every day complaining of PV bleeding, contact bleeding, and you're prescribing antibiotic, and there's no response. Why don't you just do PV examination, speculum examination? Maybe you find something. And then if you're in a place that you don't have the facilities of diagnosis, especially if you've done the PV examination and you find there's a lesion, then this is a high time that you send this patient to the next level. If you're in the district hospital, then send the patient to the regional hospital, where there is a specialist. They will examine and then they do the biopsy if it's necessary. So this is what we are talking about, high index of suspicion. You in the lower level of referral should be able to see that because of these symptoms, then we should send this patient to the higher level. That's what we are talking about. And that's also answered Dr. Shaban's. The problem is, especially in the medical school. Actually, we see undergraduates coming to Ocean Road one day, just a single day for them to be able to know cancer. That is impossible. So when they come, we just show them now this is the LINAC machine, this is Cobalt machine, this is where the patient gets chemotherapy, but it's not about what are the symptoms, what are the early, what are the diagnostic features, what are the management, you see? So I think there's like agreement with MOHAS that oncology should be part and parcel in the training of undergraduate. I think that is in the curriculum, the next curriculum that will come out. So that's all I can add up. Thank you.
Thank you very much, Dr. Okanit.
Yes, okay. So just actually answering the first person who asked question, actually from the first set of questions, yeah, I'm going to just reply two of the questions that were asked from the audience here. So the first one was on the endoscopy, the minimum number of endoscopies. So how many endoscopies should I do to be qualified as an endoscopist, or to be what? Recognized. Yeah, so I am not sure, but I don't think we have really defined a defined number of endoscopists one should do. So even in the Western world, they're actually using their tools that they use to assess an endoscopist. So you as an endoscopy student, you have to go through an assessment. Yeah, during your training. One of the tools is actually the direct observation of procedural skills, the DOPS. So it has different parameters which they assess. They are progressively as you do the course. So after that, you will graduate and get accredited and enroll to an association. I'm happy we have the TEAGIC here. Yes, so you enroll to TEAGIC, and now the question is, how do we proceed from there as an endoscopist? So when you qualify as an endoscopist, it is not done. Yeah. So even as an MD, you enroll to an association. And I'm very sure after today, the MDs and the specialist doctors in the clinical field get 4 CPD points. So can we bring that to the endoscopy side, in the endoscopy synthesis? Yeah, maybe that would be one of the ways in which you can assess. And I think it's what is being done in the Western world. So the question will be back to us, how do we go to that level of assessing our endoscopies. So back where I come from in Uganda, in the public setting, we actually have very few endoscopies. I can count the hospitals that have the endoscopy machines because I think they're costly for the government here. But the private setting now, we have many mushrooming centers with endoscopies. And then the quality of the endoscopy is coming from there. Sometimes you also wonder, you as a clinician, you've not done the endoscopy. Yeah, so how do we go about to regulate that? Yeah, so that is also a question for us to regurgitate today. Yeah. And then the next question was on mental health. I'm just going to supplement. So mental health and digestive health. So as a clinician, look at your patient as a whole, holistically. I know we have a lot of diagnostics nowadays. We're in the sophisticated world. Now that there's even AI, I can diagnose you on phone. Yeah. So when a patient comes to my clinic, I have all the tests. I can run them and get the diagnosis. But let's not forget our clinical skills. So usually I look at the patient as a whole. Sometimes the receptionist, sometimes when I see private patients, sometimes they wonder, why does the doctor take long with this patient? So interact with your patient, get the history. May come with stomach pain, doctor have stomach pain, and then you rush to the abdomen. But you may find that the patient actually has cardiac disease. So management of digestive health involves actually a multidisciplinary approach. So you need the MDTs there. So you have the nutritionist should be on board, the gastroenterologist should be on board, yeah, and many others, and other specialists are needed. Yeah, thank you.
Thank you very much, Dr. Mohammed. Would you like to chip in because you have various hats? Yeah, I know we are coming. You have several hats, and we want you to talk about the regional frameworks in terms of associations like Jamii Bora, TEAGIC, and where you are working, how we can read. So maybe, but if you have a longer presentation. No. Yeah, okay.
Yes.
Okay.
Maybe you could repeat the question so that.
Yeah, I want you to talk about how can we employ or adapt the regional frameworks to improve issues of GI.
Yes. Yeah. Thank you, moderator. Actually, I wanted to speak on the first, what are the gaps we have for the regional frameworks. As you know, there's a very limited policy prioritization for the GI disease, and we know most of the countries, they have the non-communicable strategies, and we would like, if possible, we could have incorporate GI issues on there. So most of the countries, especially in our region, need to do that. We also don't have enough sufficient data for this. And the other thing which is common is inadequate workforce and poor access to the diagnostic tool. As we can see that right now, there's a lot of innovations, which is good, but still we don't have enough tools. Then the lack of standardization of treatment protocols and weak preventive services, because we know that if we can early detect and diagnose this disease, we can be able to prevent further progression. So those are some of the gaps. Now, what needs to be done? So first, we need to enhance our policy and strategy development so that we can integrate the GI into regional NCD plan. So we can try, like we are happy that Jamii Bora partner with other organizations to ensure that this conference is happening. So if we can manage to integrate and having all these partners together, working with the government and non-government organizations to ensure that we advocate for GI to be incorporated into the in those framework. And we can just start by having the regional policies, and then country can adapt based on their demand. The other thing is now we have to strengthen in the workforce development to ensure that countries can be able to train and make sure that we have enough experts on that issues. And then the issue of research need not to be re-emphasized. We need to ensure that we do the research and get the solution, especially sometimes we can do the operational research, because those ones, they can answer a lot of questions on what can be done in our regions. And then increase the access to diagnostic and treatment, and to ensure that we have preventive services and public health advocacy on this. And then now the regional collaboration and integration with various actors. We know that apart from these societies and apart from our other partners, we can also use organizations like African CDC, which is one of the Africa regional organizations, which can also be part of this. And then we have several other regional entities which can also. Thank you.
Thank you very much. So, Dr. Mafta, you have the last word.
Thank you. I just want to respond on the doctor's question there. If there's any regional or any platform at the regional level in management of GI conditions. Of course, yes. We have, I can take example, we have been together with Kenyans, of course, in management of oncological conditions. Of course, there's a society there. Of course, there's, we say, KESHO, that's the abbreviation of the society in Kenya, and of course, Tanzania Oncology Society, and of course, the East Africa Oncology, of course, and then now the president is Tanzanian. So at least in the region, we have tried to work like that. And management, of course, of all conditions, including the GI. But of course, our friends in the region, of course, Rwanda, because we have MUHAS, the training which we do for the GI at MUHAS, and of course oncology, Ocean Road. These we receive international students, and when they go back home, we keep them on the loop. So we have been together, and now as we have that close communication of what they are doing, of course, with their patients and us. So at least in the region. But American Cancer Society had tried to unite Sub-Saharan Africa to harmonize the NCCN guideline to suit the Sub-Saharan Africa, and this had included surgeons, gastroenterologists, all the specialties, radiology, pathology, nuclear physicians, oncology. Yeah, so we have went through the guideline, and in each category, from prevention, diagnosis, management, and follow-up. So all the guideline of the NCCN to harmonize to suit the Sub-Saharan Africa. So that at least had make us together in the loop, so that we take this together. But in the tumor board issue, yes, I agree that a tumor board is there, for example, the one which was existing, but it was lacking some of the strength, especially, you know, when you talk about cancer, you need expert. There's no other way. You need expert so that when it comes to the decision making, really you make a strong decision that for the way how to treat that patient. But it has not been that strong. We agree, but recently we have sat down again, and this, as I'm speaking, it just happened this week. Another decision has been made that instead of doing that tumor board, which is just the general tumor board of everyone there, whether you are maxillofacial surgeon, whether you are breast surgeon and oncologist and gyne, whatever. So now we will do organ-specific tumor board. So that will make it easy for the specialist on the same specialty to decide on these patients. Because what has been done, maybe I can just say with my experience that I know maybe Dr. Komba here, Mwanga, Dr. Mwanga, Kitembo, Pazi, Sangeti, those Mchele. So those who are surgical gastroenterology and physician gastroenterology, so you just like, you work together like that. So we have been like that working, but of course, this decision which has been made, as I said recently, to go organ specific will make it very suitable and of course to strengthen the management of these conditions which are of course for our patients. Yeah. Yes. Thank you.
Thank you very much, Dr. Mafta. So in this panel discussion, we attempted to take a journey to inform, to discuss among ourselves the post implications of gastroenterology, but also the public health considerations in terms of prevention, treatment of gastroenterology, as well as discussing what regional framework should be developed. And I think from what we have heard, we have done, my panelists have done a good job, and you, the members of the audience, have contributed a lot, and I hope the organizers will be able to summarize and come with a good recommendation. So put up our hands again for our panelists, and thank you very much. Asante. Okay. So thank you, and we can step down. So organizers, how are we going? Tuko sawa? Mm-hmm. Okay. Mm-hmm. Okay. Okay. So we'll have one presentation, then go for lunch. When we come, we'll have the presentation from our sponsors, and then two other presentation, and then we close. Sindio? Yeah. Okay. So I'm sorry, Dr. Okanit, you have to come back again. And we are now going to talk about managing nutrition and GI disorders. So Dr. Okanit, karibu sana, and he'll make the presentation in Kiswahili. Mbona mzee Mseveni anasemaga Kiswahili?
So, good afternoon once more. So, I'm honored today to present, give you an overview on nutrition and diseases of the digestive tract. Yeah. Okay, yeah, so this is just a summary of what I'm going to go through. So I've talked about malnutrition, food intolerances, and then inflammatory bowel disease, the association with malnutrition. And we realized that actually malnutrition, nutrition contributes a lot in managing gastrointestinal disease. So the focus is on how can we manage digestive diseases with malnutrition. So this malnutrition usually results from, actually all can also contribute to GI disorder, so it's a two-way. So some actually, at times nutrition can contribute to disease of the GI, but then as well we can also use nutrition to manage these diseases or disorders. Yeah, and malnutrition occurs in different ways. Poor absorption, you're eating but you're not taking, and can also occur in patients with chronic disease, that is chronic inflammation. Yeah, so patients with IBD for this case, the focus of this discussion, and other diseases, yeah, that lead to inflammation. Yeah. So as I talked about, so that is inadequate intake could be one of the causes. And then you also have malabsorptive syndromes in malnutrition. Yeah, so some of them, of course, could be autoimmune diseases, yeah, celiac disease. Could also be having atrophic gastritis. These things contribute to malnutrition in patients. And of course, talked about chronic diseases. Yeah. And you also have increased nutrient requirements. Patients who have severe disease, yeah, or patients who have endocrine diseases, hyperthyroidism, and the rest here. So that risk of malnutrition. Yeah, of course, the signs are actually what? Usually, we all commonly see the signs here. Weight loss, muscle wasting, fatigue, and the patients don't have actually poor healing. I mean, have poor healing of their wounds most of the time. So it's important for you to assess those patients. Don't only concentrate on the wound, but also do a full assessment. You may find it's nutrition, yeah. And of course, patients who are immunocompromised. Yeah. So we have some nutrition assessment measures, yeah, that are used. Actually, this most of the times are done during triage. So it's important for all patients who come to your clinic to undergo actually these assessments, yeah. So usually they help us in the triage. So anthropometric measurements, yeah. HAPA, the pediatrics usually do it a lot, so we also need to adopt it in our adult patients, yeah. And we also have some biochemical markers which can also be used in assessment of malnutrition, yeah. And the full history on intake of actually the nutrients should also be established in these patients who are at risk of malnutrition. And other functional assessments here. We have hand group measurements here, and then the weight bearing measurements, which you can, measures which you can usually use to assess what? Malnutrition in these patients. So management would starts from the intake. How do we improve the intake of these patients? You encourage actually what? A high calorie diet, yeah, and then also protein-rich diet in these patients. You also need supplements where need be, which could be from multivitamins, yeah, and then also the micronutrient supplements. And for patients who are usually very ill, sometimes parenteral feeding may be necessary, but this should be done with caution, yeah, taking in mind that we have actual also what? Side effects or the downfalls of parenteral nutrition in these patients, yeah. And of course, look out for the underlying, yeah, pathology, GI pathology in these patients, yeah, as we had said earlier on. Yeah, so I'll give a brief also on the food intolerance here. So this would so patients who have food intolerance may actually be what? So may present with many dyspeptic symptoms here. So will someone raise the question about what? Yeah, about involving other aspects in management of patients with GI disease. She talked about mental health. One of the aspects we should also include in management of GI disease is actually the nutrition of this patient assessment in patients who present you with dyspepsia. So some studies have been done and have shown that actually there are some patients who get intolerance to this food. It could be due to allergic components, but at times it could be mild chronic inflammation they get. Yeah, of course, there are those who have autoimmune diseases like celiac disease, they're at risk of getting these food intolerances. Yeah. Of course, these are some of the food intolerances that you will encounter. I've just given an overview, just given bullets in this, but we will not go in depth into them, of course, And I'll talk about the FODMAP sensitivity. The FODMAP diet, you're going to find it actually being talked about a lot in literature, contributing to nutritional disorders, and also being used in management of nutritional disorders in gastrointestinal health. Yeah, so FODMAP diet is actually a diet which is rich, it's also referred to as the Mediterranean diet, rich in vegetables, rich in sweets, and then also dairy products. Yeah, so there are some patients who have been found to be very sensitive to these kinds of diet, and actually elimination of the FODMAP diet at times has actually shown improvement in symptoms in some of these patients who get dyspepsia or digestive health disorders. Yeah. So that is elimination diets, management of that, and then of course gradual introduction of foods at times which the psychiatrist would tell you, flooding, in some of the aspects, and then also these patients, besides lacking those other nutrients that we have talked about, the major nutrients, the proteins, and then the energy-giving foods, the carbohydrates, they also lack some some micronutrients, the vitamins, and then also the zincs, the micronutrients, the trace minerals, So that is, and of course, all in all, you have to come up with a personalized dietary plan for these patients. So one patient will come to you, or rather 2 patients will present you with similar symptoms of dyspepsia. I get full when I eat this type of food. So when you explore the other patient, you may find that it is the food that the other patient responds to well that they don't tolerate. So it's usually personalized dietary plan. There are no clear-cut guidelines, or rather no clear-cut literature to guide us on how to or rather on which foods are actually necessary or recommended in management of these food intolerances. And the last what I'll talk about is the role of nutrition in inflammatory bowel disease. So it has a possible role, in what diet itself has a possible role, or has been actually associated. So Mark quote me, it's an association, it's not a causation. It's been associated with inflammatory bowel disease or increasing the symptoms of inflammatory bowel disease, bloating at times, and then also abdominal pain, and then also the bowel habits. Now, some of the foods that have been talked about, or the nutrients you find in literature, will be proteinous food. At times have been associated with increase in the symptoms of these patients. And then also fatty foods. So what is actually what are some of the theories behind it? So protein actually is associated with what? Some of the theories behind it is you digest your protein, and in the end, you get what? You digest the protein, the end products reach the colon and induce an inflammatory reaction. It's not really clear, and it's the same thing that is also associated with fat. Digestion of fat to release what? It's not, with digestion of fat and then to release the reactive oxygen species, which actually exacerbate the symptoms. The other theory behind the fat and inflammatory bowel disease is actually it also tends to increase the visceral hypersensitivity of these patients, and also associated with, especially and increasing visceral hypersensitivity, and then also increasing the production of the acid, and patients tend to get more symptoms of disease. So these are theories, but it's not really clear-cut that how they present here. So that is one of the ways in which, but then at times these patients need these nutrients, and we use these nutrients actually, of course, what? To manage these patients. We need the food, yeah. So they have chronic inflammation, and then they don't have an intact what? An intact colon. So they get poor absorption of nutrients. Some of the nutrients could be the vitamin B nutrients, which are needed, most of them are absorbed in the colon, especially vitamin B12, but vitamin B12 is physically absorbed in the terminal ileum. So they get malabsorption, and then at times because also sensitivity to the foods they don't eat. So they also have what? Yeah, a lot of challenges in nutrition. Yeah, and of course due to the chronic inflammation, they get increasing needs, yeah, and they get at risk of malnutrition. So what are some of the strategies that are being used or recommended, yeah, to manage inflammatory bowel disease or manage the symptoms of inflammatory bowel disease? So one of them is the exclusive enteral nutrition, especially in Crohn's disease. So this has mainly been done in the pediatrics. When you read literature, it's been done actually, especially in the pediatrics, not so much in the adults, but of recent, we are actually also adopting it. So the exclusive enteral nutrition actually involves the introduction of nutrients, foods in liquid form into this patient's colon. It could be through an NG tube if they can't eat, yeah, mostly, yeah, but it can also be taken orally. Yeah, so the nutrient-rich what? Formulations in liquid format. And then, of course, the other one could be identifying the triggers. Yeah, as I said, it's an individualized approach in management of, yeah, of these conditions. Yeah, and then the high-fiber diet, which has been shown to be protective, but then also it could also worsen the symptoms of IBD, because we realize that the fiber is not, we don't have actually enzymes that digest the fiber in our gut, specific enzymes. So most of the times, the fiber helps us to evacuate our bowels, but at times could also cause more symptoms of bloating and abdominal pain in the colon, yeah, in patients with IBD. And of course, I talked about vitamins and micronutrients, yeah. Some of them have been shown to be having antioxidant properties, like vitamin A, and then the rest, and then also some micronutrients like zinc here. The minerals here have also been found to be of what? Significance in these patients with IBD. So I'll end with this point, emphasizing these points that we need actually what? An MDT in management of patients with digestive disorders. Yeah, and we have challenges with, especially related to nutrition. Yeah. Okay, and of course we need an individualized approach in management of these patients. Yeah. Thank you.
Thank you very much, Dr. Anthony, for that. We know we captured you very with the short notice, but you managed. Thank you. And I would like to invite now if there are any contributions, questions, and rejoinders to that presentation. Karibuni. Anyone with anything you want to raise? Yes. No, it's lunchtime, eh? Because we've spoken of GI and nutrition. Now, people, is the lunch ready? Or okay, we can go for lunch and then come. But when we come back, we will have a CME, which has been is on our program on urea breath test, and then we are going to have to hear our sponsors to say greetings, and then we'll have some two last presentations of the day, and then we'll finish. So I hope lunch is ready, Cindy. Okay. Okay, while we're waiting for lunch, who wants to say something? There was a question, Dr. from the chat box, but it came late after the presentation was made. So maybe let me read it, and if you can respond. What was that, Doctor? Yeah. The question was, what are the measures taken so far in Tanzania to prevent the colorectal cancer and esophageal cancer in the older adults population? I think it was for you, eh? Yeah.
Thank you very much for the nice question from the online platform. It was more on what are the measures taken by Tanzania to prevent colorectal cancer as well as esophageal cancer. So there are several measures taken by the country with regards to our Ministry of Health. And one of it is the public health education and awareness. And this has been done through radio, television, as well as community outreach from different hospitals as well as platforms. One of the members in the audience has been advocating that we should actually make it more sound through social media and our society. The other measure that has been used to taken by the country to prevent is having these specialized centers such as Ocean Road and other cancer institutes that have been built in the Lake Zone, like in Bugando Hospital. This has been one of the key preventive strategies to bring close to the community the services. As well as there are collaborations and the partnership within the Ministry of Health and the country. We have for esophageal cancer, the African Esophageal Cancer Consortium that is actually working with the East African Corridor, as well as in our Tanzania, this Africa works with MUHAS and some neighboring and partner hospitals in the country. We also collaborate with it. So it plays a key role in the preventive ways of esophageal cancer. Thank you.
Thank you very much, our online participant, for the question, and Doctor, for your response. Now I'm informed that you want to say something? Yeah.
Just to contribute or to comment from the previous presenter about nutrition in GI condition. Nutrition in GI condition is a very important topic because, as we've seen, these patients they are passing through a chronic illness and they are deprived of several nutrients, minerals, vitamins. Take an example of a patient with liver cirrhosis. They are depleted of a lot of protein, muscle breakdown, and they need a special kind of intervention. For example, for patient with compensated liver cirrhosis, we do need to do protein restriction, but for patient with compensated, still they need protein, but you need to be very careful a type of protein you should give. You need to give branch protein that has high content of branched chain amino acids, like the one from fish, legumes, milk, unlike the animal fats. But also the requirement for supplementation of protein varies from those of general population, in which you need to supplement by giving at least 1.2 to 1.5 gram per kilogram per day. But also they are depleted of calories, in which you need also to supplement by giving 35 to 40 kilocalories per kilogram per day. but also other conditions as presented, like patients with pancreatitis, for example, one of the GI conditions. You need to give early oral feeding, because studies have shown that oral feeding improves survival. But also for those with chronic pancreatitis, we need to, they are depleted of several mineral and vitamins, especially the fat-soluble vitamins. So you need to supplement them, not only by giving pancreatin, not only the replacement of the hormone, but also the vitamins, fat-soluble vitamins. And so many conditions of the GI, some of them we have seen the patient that can have Crohn's disease, which can predispose them to short bowel syndrome. Short bowel syndrome is not merely due to surgery, where you have the size of the small intestine less than 200 centimeter, but rather it can be due to medical conditions like Crohn's disease. So these are the patients you need to supplement them. You have to make sure that you correct the deficient vitamins, proteins, and other minerals. And sometimes some of them they might need parenteral nutrition, though if you compare the two, the enteral nutrition is superior compared to parenteral. So these patients with the GI condition, we have to take them with, we have to manage them with conscience, holistically, taking into account all the complications, the nutritional complications that succumb due to their chronic illness. Thank you.
Thank you very much for that contribution. And if there is no other contribution, yeah, there is one there. Nani akunisaidia mic? Yeah.
Thank you. Looking at the Western dietary patterns rising in the youth culture in Africa, how are public health systems responding to the rising tide of non-communicable diseases without losing sight of cultural food traditions in this region, the East African region?
So that's the question for Dr. Okanit. Karibu. Yeah. The online people can hear you but cannot see you unless you come in front.
Yes, thank you for that question. Yeah, so public health and nutrition in Africa. Yeah, so we have a lot, as from my presentation, we noticed that actually I mentioned that we don't have clear-cut guidelines, or rather we don't have writing on the stone that says that this type of food causes disorders or disease of the gut. Yeah, so it's usually it is an individualized approach, first of all, to management of nutrition. So coming back direct to your question, culture and nutrition in Africa. So we have a lot of myth in our setting currently, yeah. And there is also, actually, it also involves also the use of other non-medical strategies in managing diseases using food rather than nutrition. Yeah, so you find patients have gone to herbal medicine and even supplements, yeah, to address those problems with nutrition. Yeah, so maybe it is high time actually that, so we don't have yet clearly a guideline, or rather something that merges our management of medical management and then also cultural or rather the traditional practices. Yeah, but of course that is food for us to think about. So how do we merge these two or three medical and then non-conventional measures in management of nutrition? Yeah, nutrition disorders in our culture or setting. Yeah, so. Thank you. Yeah. Have I addressed you? Okay.
Yeah, thank you. I hope we've satisfied everyone. So, Dr. Sangay, si yule kule, au sio yule? Si yule kule kwenye kona, au sio yeye? Dr. Sangay, can you stand up, please? We recognized you when you are not here. That's the one who enabled our CPD points, and they're asking for the other health cadres for the next meeting. So you can greet them. Mpe awasalimie.
How are you?
Is it?
Assalamu alaikum. Good afternoon, everybody.
Good afternoon.
I'm Dr. Taufik Sangha. Professionally, I'm a radiologist and a CPD coordinator of Jamii Bora Health Service Network. Thank you.
Asante sana. Okay. Okay, so let's go for lunch very quickly and come back. When we come back, we'll have the CME. Okay, and then, so the organizers have some announcements. Karim.
So thanks very much, everybody, for the very nice and vibrant sessions we had since this morning. And now it's marking that we go for a quick lunch break. And if I see, it's almost 1:33. So I think we can use the 30 minutes for a quick lunch break. And when we come back, we'll have some two presentations. And then we'll have some greetings from our sponsors, a small CME on the use of the urea breath test machine, and then we'll be able to close the session. And another issue is on for the guests. The restrooms are just when you go out, you'll see the booths, and then just around the corner, you'll have the restroom on your left. And I'm told the lunch is ready, so bon appetit. Usually after lunch, people usually sneak out, but we are happy to see most of people have come back. We'll have a very brief sessions, 2 or 3 of them. One will be the short CME on the urea breath test machine, which will be showcased by our colleagues from Headway and RIMA. But I want at this particular time also to make some of our sponsors ready. Shifa, so be somewhere around. We will call you in no time. But also Binto, wherever you are. So your session will be coming shortly after this. So get prepared. You'll have 10 minutes. So gear up for that. So once again, I'll be taking this session briefly from Dr. Ipuge. And without wasting much time, we welcome anyone from Headway / RIMA, and what we expect from you is the short explanations on the use of the machine, and perhaps we may use the time also to do some greetings from Headway, and anything from that particular side. The audience is yours. You're welcome.
Okay, good afternoon, ladies and gentlemen. My name is Jessie, and I'm here today representing Headway China, which is a global leader of H. pylori urea breath test industry. First, it's a great honor to be part of this event. I'm so excited to bring a practical golden standard diagnostic solution for H. pylori diagnosis, which combines enhanced accuracy and efficiency that can address the current clinical challenges in East Africa. So please join me to take a virtual journey to our company by our video. Our vision is to make the pursuit of health easier. This is our manufacturing system. The entire manufacturing process is highly automatic. No voice. It's okay, I will make a detailed clarification. We have established a modern and intelligent manufacturing system to support a high quality and large-scale production. From capsule, collection cards, and test case packing, even warehouse management. Okay, next, please allow me to make a detailed clarification of our company. Our company was founded in 1996 and is a state-owned enterprise under China National Nuclear Corporation. Relying on its resources, Headway has gone from strength to strength. Now, we have been the world #1 urea breath test supplier with both carbon-13 and carbon-14. In past 3 decades research and development, Headway has built a good reputation in the domestic market. We have been honored with numerous awards. Among these awards, National High-Tech Enterprise Award is considered as the highest recognition. It proves that Headway has a strong technological innovation in production of urea breath test. Now, we have 3 research and development centers and 3 manufacturing centers covering a production of over 70,000 square meters. In addition to the strong research and development ability, we also established a modern and intelligent manufacturing system, from capsule manufacturing, collection card, to test kit packing and even warehouse management. Besides that, we also passed multiple international certifications and established an international quality management system. We got CE, ISO 901, and GMP. This is a general overview of our global market presence. In the past years, Headway has offered solutions to over 20,000 medical institutions in over 86 countries and regions. From Asia, Latin America to Europe, Africa, and the Middle East, helping millions of people benefit from the accurate and non-invasive diagnosis method. We believe that in the near future, we can bring more value to more customers, especially in here, East Africa. Let's have a quick look at our annual sales revenue. In the past 5 years, Headway has maintained a steady growth. In last year, our annual sales revenue surpassed $486 million. Behind this growth is our high quality and global engagement. You will find us at DDW, APDW, UEG, and the Medica and other regional GI conference or medical exhibitions. So next, please allow our colleague, Andrew, to make a detailed introduction of our cutting-edge technology. Thank you.
Good afternoon, everyone. My name is Edwin Semakuya. I am a biomedical engineer by profession, and I work for a company called RIMA East Africa Limited. RIMA East Africa Limited is a biomedical engineering company that specializes in distribution of medical equipment across East Africa, with branches in Uganda, Tanzania, setting up one in Sudan as well. On this occasion, we partnered with Headway because of their new cutting and innovative technology, as we are going to see. Throughout the presentation, the previous speakers, the likes of Dr. Ahmed, the president in his absentia, and so many who have spoken before me have highlighted the need for solutions, innovative solutions to combat the early diagnosis of H. pylori, because we can all testify that H. pylori is they call it it's classified under class 1 carcinogen, right? It causes cancer, so it's classified under class 1. Now, this innovative technology that I'm going to present to you is one of the solutions that we believe, once implemented properly, can revolutionize or try to bring a solution to a solution that we've been looking for, because we've been talking about innovative technologies, how we can standardize H. pylori screening, for example, and the likes. So the machine before us today, it's called an H. pylori machine, HUBT20P. For those who can't see, this is the machine here. Yes, this technology, we are basically testing H. pylori in patients, but it is completely non-invasive. So there is no piercing anybody, there is no need for endoscopy at this level, okay? And it has been branded as the gold standard in terms of detecting H. pylori. How? With this machine, it comes with what we call a rare capsule that a patient takes, okay? So for example, it's required that somebody takes a patient probably 3 hours prior. The best time to do this test is probably in the morning when someone has not yet had breakfast. However, if somebody has not had still breakfast like 3 hours or 4 hours prior, they are very good candidates. So somebody comes, they are given this capsule. This is a rare capsule. It's not a drug. Everything gets out of your body within 12 to 24 hours. So in this capsule here, this is what we call urea, okay? Now, as we all know, my dear professionals, that H. pylori produces what we call urease, yeah, in our gut. So the urease that it produces is the one that is responsible for breaking down this urea capsule into two compounds. That's the bicarbonate compound and the ammonium compound. Now, we are interested in the bicarbonate compound, which is labeled, it's a carbon compound with isotope 14, okay? It's a carbon labeled 14. So once the urea produced by the H. pylori breaks down this capsule into the two compounds, the bicarbonate and the ammonium compound, the bicarbonate is going to be absorbed into the bloodstream. And eventually, it's going to go to the liver for us to exhale out as we exhale out the carbon dioxide. Now, from the time the person takes this capsule, they just sit somewhere for 15 minutes. In the 15 minutes, what I've described earlier is taking place. The urea is being broken down by the urease produced by the H. pylori in our gut. So we believe within the 15 minutes, we'll have, most of it will have already been broken down, and therefore it's being exhaled as we, through our normal breathing in and breathing out. So after the 15 minutes, the physician handles over, this is what we call a collection card, to the patient who has taken the capsule, okay? So they hand over this very sensitive collection card. This collection card is usually here. It's usually yellow. So they give you this collection card, then the the patient blows into this collection card for about 3 minutes until it turns orange. Why do they blow into the card? Is because we are trying to capture the carbon-14. That is, remember we are breathing it out concurrently with, in carbon dioxide with the normal isotope of carbon-12. So this is capturing the carbon-14, ideally. So once it turns orange, then it's as good as just you get this card and place it into this machine, and the machine will do the rest. The machine will detect, it will measure what has been captured, and this takes about 4 minutes and 10 seconds to be precise, and it will give us a value. Now the value it gives, it's both qualitative and quantitative. In other words, it's going to give us a negative value and a positive value. However, when it gives you a positive value, it's going to attach a number to it. For example, between 0, the carbon value that it gives is between 0 to any number. However, less than 40, that person is negative. All right? Then above 50, that person is positive. Now, the higher the number, for example, 100, if it gives a count of 100, or a count of 200, or a count of 300, that shows you the severity. The physician is able to tell the damage that, or the amount of H. pylori and the damage it is causing to this person. Because a person, if it gives me a count of, let's say, 70, and it gives another person a count of, say, 300, that means the other person is not doing well. Therefore, the physician is at will to actually go ahead and maybe ask for an endoscopy, for example. Yeah, but that's already, we've already gotten proof that the person has H. pylori in their gut. So the whole process takes roughly 20 to 25 minutes, and you have the result. Yeah? It's a very maintenance-free machine. It doesn't require any reagents. The only calibration that we do on the machine, we have a standard card that we always run every 2 weeks or a month for it to calibrate itself. There are no reagents. There are no. The only consumable we have is this, ideally, and the collection card. So within 20 minutes, we have our results. It's non-invasive. It's recommended out there in Western countries. Nowadays, it's become mandatory that people above, even children above 12 years, they go and test. Yeah? Now, here in Tanzania, or in the sub-Saharan region, for example, we know that we have a prevalence of about 75% of us, or of the population, is in one way or another infected with the H. pylori. So if we could standardize this, like somebody mentioned earlier, whereby if somebody goes for a medical checkup, they also do this test as well, because it's only 20 minutes, and it's completely non-invasive. So somebody can walk in and get out. The only people who are exempted at the moment from doing this test are the breastfeeding mothers and expectant women. Not that there are studies that show that the carbon in here affects them, but because of their very sensitive nature during that time, it's not advisable. I'd not talked about the ammonium compound. The ammonium compound is also excreted out of our system completely, 100%, within about 12 to 24 hours through sweating, through urinating, and other ways we excrete. So everything completely gets out of the patient's body within about 12 hours. Now, I'm going to invite my friend, my colleague, Bruno, and to give you an in-depth analysis. But in a nutshell, just to recap, somebody takes this, they sit somewhere for about 15 minutes. After the 15 minutes, they are handed a collection card, which they blow into until this turns from yellow to orange, this color code here. And then after that, the physician just puts it into this machine, and the machine does the rest. All the chemistry and everything is into the machine, and then automatically, it has a printer here, it will print the results, which the physician then can interpret and go ahead to give a diagnosis or a way forward, depending on what they've seen. Thank you very much.
Good afternoon, ladies and gentlemen. My name is Bill Bruno Senkole, and I'm a pharmacist. I'm overjoyed to be here with you. Thank you so much for hosting us in Tanzania. It's my first time here, and it's so far so good. So basically, I'm here to talk about the significance of the urea breath test in a nutshell. Why is it called the urea breath test? Why isn't it called the nitrate test or carbon test? Why is it called the urea breath test? And I would also like to stress it out that there are two urea breath tests. That is the C14 and then the C13 urea breath test. What we have here is the C14 urea breath test, and it's what we came to give to Tanzania. So the reason why it's called the urea breath test, it's because of the principle with which this test operates. And above here is the principle. He highlighted it in his presentation, but I also like to stress out a few things in there. So we are having this capsule. He talked about the components of the test, and the number one component is this capsule. And now this capsule is not a drug. It is NDA in Uganda classifies it as a food. The reason why NDA classifies it as a food is because it has no pharmacodynamic properties, but definitely it does have pharmacokinetic properties because it's excreted, it's metabolized, all those are pharmacokinetic properties. So this capsule right here contains urea. Now the urea that is contained in this capsule, like he said or mentioned, has its carbon labeled 14. That is to differentiate it from the carbon dioxide that we have in the atmosphere because it is carbon 12. Now this urea is hydrolyzed, like you can see here. This urea, after being ingested by the patient, it is hydrolyzed in the stomach or in the gut by the urease which is produced by the H. pylori. How does the urease come about? We understand that the H. pylori exists in an acidic environment, but then how does it survive? It survives by producing urease, which urease goes ahead to neutralize its environment. In that way, it is able to survive in an acidic environment. So when this patient ingests this capsule right here, it is going to, the components of the capsule or the constituents, which is the urea, is going to be hydrolyzed by the urease produced by this H. pylori. When this urease is hydrolyzed, you're going to have two products of hydrolysis, that is the bicarbonate and then the ammonia. Now the bicarbonate, definitely with the ammonium, is going to be absorbed in the gut, in the small intestines, into the bloodstream. So the ammonia, you let me concentrate on the bicarbonate, please. The bicarbonate will be transported to the gaseous exchange center. When it's transported to the gas exchange center, it's going to dissociate into water and carbon dioxide. Now, the carbon in this carbon dioxide, this is the reason why the test or the patient is asked to take this capsule and sit for 15 minutes. There are lots of factors surrounding these 15 minutes that directly contribute to the specificity and sensitivity of the test directly. And if it's messed around with, you may end up having false positives or false negatives, whereas the testing itself hardly gives such results. So the patient is rather at the gaseous exchange center. We are going to have the patient exhale out this carbon dioxide into the breath card. He mentioned the breath card. Right over here. This is the breath card or the collection card. This is used to collect the sample. The sample therefore here is the carbon dioxide. This is what we are most interested in. The carbon dioxide has the carbon labeled 14. Now this card right over here is sensitive to the carbon 14 isotope. It is very sensitive to the carbon 14 isotope. So it will capture it, and it has a center. As you can see, there is a center which is colored. This center right over here is an indicator. It indicates saturation. It does not indicate results of the test. It indicates saturation, that this card is saturated with the sample. And how does it show you that it is saturated with the sample? The color here will change from yellow to orange. Now, for some of you here, maybe you could have, this is majorly for the laboratory technicians, they could have maybe color challenges, differentiating between one or two colors. I made a test just outside there. I was inquiring for somebody. I asked them, which color is this? Dr. Sai, if I may find out from you, could you differentiate these colors, please? There are two colors right over there in that capsule. So doctor had to inquire from someone with better vision. Thank God for better vision. All right. Yes, so we're having yellow and then we are having orange. Now, the reason why the manufacturers of these tests, which is Headway, represented by our colleagues here, Mr. Lee and Jesse, they made it in such a way to help you, to help the laboratory technician to differentiate these colors, because it's very important. If the laboratory technician cannot clearly distinguish between these two colors, they might end up retrieving the card from the patient, whereas it is not saturated with the test. And all of us here can definitely tell what the result of the test will be. It could be a false negative, therefore. See that? So these two colors, there will be that color change to indicate the saturation. So after that, he talked to you about the whole procedure and all that. But I want to specifically highlight the significance of this test, the urea breath test. The previous panelists talked about innovative methods of diagnosis, especially for such prevalent infections like H. pylori, and they talked about the urea breath tests as some of the new methods that should be adopted. Well, it is true, they should be adopted. The World Health Organization recommends so. The World Gastroenterology Organization recommends so. This is a test that has been used in screening, prophylaxis of the same infection. Now, Dr. Anthony, and I paraphrase, made a statement here and said that in diagnosis, we have precision methods like endoscopy, which play a very important role. But at times, this endoscopy is going to be performed on the patient at the very time when the patient has, they are presenting with every symptom of the disease, and then it is passed. So literally, you could not arrest the patient from, you could not help the patient from progressing into the disease. Because we are having this H. pylori, and then the patient is infected, but it does not necessarily mean that they should develop the disease. So can you help them? How can you help them if the methods that you're using to diagnose are not such precise? This is the reason for the development of the urea breath test, because the urea breath test has been labeled a gold standard test. By that, it means it is very much, its precision is quite high. I mean, it's high, not even just quite high, it's high. So it solves the challenge of doing an endoscopy when the patient has already developed, the disease. So we could help them. We could help them. How do we help the patient using the urea breath test? It is very simple. So from this principle here that I've just highlighted to you here, we can conclude on a few things. Number one, we can conclude that the test is going to give you the result basing on an active infection happening in the gut of the patient. How so? The H. pylori, I just informed you that is going to produce the enzyme urease. If the H. pylori is eradicated and non-resident in the gut of the patient, there is not going to be sufficient concentration for the urease to hydrolyze the urea. If the H. pylori was eradicated due to the therapy, perhaps the patient performed the test prior and then they were found positive, for example, the RUT or the stool antigen test or the blood serum, and then the patient was found positive, and then they went, the clinician went ahead to manage the patient, and then the outcomes of the treatment was so that the H. pylori was eradicated. This test, therefore, is going to show you that the patient, rather the H. pylori in the gut of this patient was eradicated. Therefore, you might have to perhaps take them off the regimen or proceed to any other treatment decision and management decision accordingly. So how does it help out with ensuring that endoscopy, number one, remains the confirmatory test and the standard test for the diagnosis of the same infection? This is how it does it. The H. pylori, the urea breath test, I will use C14 in this instance. It has two results. The result number one is the qualitative result, which is the patient is going to be positive for the infection, or the patient is going to be negative for the infection. He hinted on it. He said that then the other, allow me to skip this for a moment, the other result is the quantitative result. Now, the quantitative result is very vital. This is what is going to help you, okay? This is what is going to help you so that you can help the patient as a clinician or a doctor. The quantitative result in such a way that you are having a range of figures. So you are having, the test will give you a range of figures from 0 to 40, and then from 50 going above. So from 0 to 40, the device will tell you that this patient is negative. Then from 50 and above, the device will tell you that this patient is positive. But you can see these are figures, these are numbers. They are indicative of the activity of the H. pylori in the gut of this patient. So when you find out that this patient is positive, all right, at what concentration of the H. pylori in the gut, you can go ahead and make a decision to put the patient on treatment, or go ahead and do an endoscopy to find out what you're actually seeing using the urea breath test. So what are we concluding or deducting at? We are deducting at the very point that the urea breath test is a gold standard test for precision diagnosis leading to precision medicine. So thank you so very much. Allow me to stop here for now. Yes. He could highlight just a few things regarding the sensitivity and the specificity of the test. All right, he has asked me to. Thank you. So we can talk about the sensitivity and the specificity of the test in comparison with all the tests present, okay? So we are having the invasive ones, of course, which include the RUT, the culture, histology. You require for example, the RUT, many of you here are doctors, clinicians, perhaps you've performed it. These are invasive tests. The sensitivity of the RUT ranges from 75 to 98. The specificity ranges from 70 to 98. As you can read from here, the culture, the specificity definitely is 100%, and then the sensitivity 70 to 92. Now, let's proceed to the non-invasive tests. We are having the stool antigen, whose sensitivity is 89 to 96, then the specificity 87 to 94. So in comparison with all these tests that we are using today, with the urea breath test, and in the urea breath test we're talking about both the C14 and the C13, we can see that the sensitivity is way above, up to 99%, and then in fact for both 99%. The World Gastroenterology Organization has confirmed so, that the sensitivity and the specificity of this test is up to this figure. Headway, the manufacturers of these tests are not just making up the results. We have clinical studies. If you could pass by our booth, we can show you these studies that back up this information, clearly with you. Of course, including other documentations and certifications. Yeah, so from this information, we can definitely conclude that the urea breath test can be used for screening, number one. And then it can also be used for monitoring the progress of the infection. And you can also use it to make correct, timely treatment decisions for your patient. Yes. Is there any other thing? Yes. All right. Thank you so very much. Thank you again for having us here.
I'm told we still have some time. So in the concluding remarks, I wanted to highlight just one thing. These are some of the areas where this machine is used in the clinical lab, endoscopy, pediatric department. Yes. Now, who should be treated for H. pylori? Of course, we have them up there: peptic ulcer patients, gastric maltumor patients, chronic gastricitis accompanied with dyspepsia, as a doctor here talked about, then patients with family history of gastric cancer, long-term users of PPI. Now, here's what I wanted to note. We are all, I know you have more medical knowledge than I, but when it comes to if somebody has been using PPIs for quite some time and antibiotics, then it's recommended that at least we do that test maybe 2 weeks after, because of course these PPIs, in a way they will affect the results. So we might get false negatives or false positives because of the way they react with the acidic nature in the gut or in the stomach. So it's recommended that if somebody has been undergoing medication involving antibiotics and maybe PPIs, they come for the test maybe 2 weeks after they are done their medication. That I wanted to highlight. Otherwise, thank you very much. The device is already registered with TMDA, and we are looking forward to partnering with the various hospitals across the country for this very great innovation from our colleagues. Thank you very much.
Thank you very much for that, carrying us through this theme on urea breath test. So I would like to invite 2 or 3 questions or comments from the audience. Yes, please. Yeah, come and read.
Okay, thank you very much, Edwin, and thank you, Edwin and Bruno. So my question is on the capsule 14 and 13. Is there any difference in the results? And then for headway, do you make only carbon 14 or you also have 13?
Thank you, Dr. Anthony. Actually, we have a lot of installation in Uganda, like C-Care Hospital. We were in Kampala from Monday to Tuesday. And thanks for the nice question. Actually, we have both C13 and C14 urea breath test. And the difference between C14 and C13 urea breath test is C14 is the radioactive isotope. But this radioactive isotope is used for urea breath test. It's very sensitive and it's very safe. We have the exemptions from the United States FDA and also China FDA. So one UBT, one C14 UBT test, the dose is just 0.75 microcurie. So the radiation of one UBT test equals to taking 1 hour's flight or 24 hours background radiation. So it's very widely used in many countries. The reason why we introduced this C14 first into East African countries, because it has been widely used and widely used in China and many countries, and it's more affordable, more friendly, because the device is very friendly to the environment. So that's why we introduced the C14 urobase test here. Yes, thank you. Yes, please.
Thank you, RIMA Limited, for the nice presentation. Yes, as you presented the urease breath test as the gold standard,
yes,
with a very good sensitivity and specificity of around 99%. So making it a very good test for H. pylori, a non-invasive test. So what about the test, the cost of one test, taking into consideration the society we are taking care of? So we need to know the cost implication of a single test.
Thank you very much for the question. Just like I mentioned now, we are bringing a more affordable test here in East Africa. But since this is a very advanced technology, so compared with the stool test, our price is a little bit higher than stool test. But it's more friendly to the lab staff, to the doctors, and to the patients. I think maybe at the very beginning, the price may be a little bit higher. A reasonable UBT for the patients is around $25 to $30 in many countries, is on average. But in East Africa, we'll try our best to make it lower, to let more people can experience this good technology. Thank you. For the patients, right? $25. Yes. Thank you.
Now, maybe just to add on that, that $25 is relative. We have different pricing schedules. For example, there's a difference when you buy the machine and when we do place the machine. And we also have a very good flexible rate. So we come to us and we discuss and we see how, because we want to make this as affordable as possible for the everyday person as well, because that's why we are here. So it could go to as low as maybe $15, but it depends on, for example, there are some dynamics, I would say, yes, that are very key and vital. Yes, please.
Any more?
Thank you very much for an interesting technology. We clinicians who have just been reading this from the books. In Tanzania locally, we normally order the stool test and the blood test. So this one is a bit new for most clinicians in Tanzania. So we, especially in Dar es Salaam, most of the patients are using insurance, like NHIF and other private insurance. So to make the issue of costs, did you make any consultations for the insurance companies in Tanzania so that they can incorporate these tests? Did you make that effort?
Yes, of course. Actually, our company is a state-owned company. The Chinese government owns our company. So being here in East Africa, it's not just for business. We are trying to bring more health care to our friend here in East Africa. So we'll try our best to talk with the insurance company. And also we are going to have a meeting with the MSD here in Tanzania. So maybe in the very near future, this very advanced technology can be very widely used here in Tanzania with the covered by the insurance. Yes.
Maybe just to add on that, in Uganda and South Sudan, we're already having so many private hospitals, for example, that are using the insurance premiums for their patients. So we do believe that even here, it will not be any different. We'll try to talk to, or we're already in talks actually with the director of, he was supposed to be here today, the director, like medical stores. Yes, he went to Dodoma, but yes, NMSD. We're already in talks with that gentleman, and I think it's going to be positive, and we'll see how to carry forward.
Thank you very much.
Thank you.
Thank you very much for your presentation, for the questions and the responses. Maybe because I'm more closer to the policy makers, I think for your last question and for the question of pricing, I think the Tanzania Gastroenterology Society has a big role to play in that. Because in the next revision of the standard treatment guidelines, if you find this test is important and include it in the STG, then NHIF can cover it. So even if you go and talk to them, if it's not in the STGs, it will not. So it's up for the Tanzania Gastroenterology Society to work with the Headway and RIMA to kind of do some local research test evaluation, proof of concept tests, and then prove to the ministry that we need this. Because they've shown that among the non-invasive, it is the best. In the invasive one, there were two which were, the culture is 100% sensitivity, and the other one was histology, was closer was on the similar range with this. But for the non-invasive, it's non-touch. So it's up to you people in the Gastroenterology Society of Tanzania and Uganda and whatever. But for Tanzania, if it's not in the STG, NHIF will not cover, maybe the private insurance. But because the standard guideline is going to be revised soon, so the Tanzania Gastroenterology Society must make its presence felt. So, and make sure that it's included. Then and maybe you can help them do some of the proof of concept research. It has been proven already, but show the value add in Tanzania. If you introduce it, how many patients you will save, how many early diagnosis will save, how much. They talked about the economy in the morning. So if you identify early, how much money will you save? Well, so the initial cost, even if $25 is high, nobody will afford, for the test. But if you look at the whole chain, it might be useful. Sawa, kwa hiyo kazi kwenu, si ndio? Wataalamu wa Gastroenterology Society na jamii bora. Okay, thank you very much. Thank you very much again, and I would like to invite Shifa Pan-African to introduce themselves, and they are one of the sponsors. Okay, Headway Rima is, you have already introduced yourselves, Cindy? You have already introduced during the presentation. Yeah, you already finished, so Karib.
Yeah, good afternoon, everyone. Yeah, my name is Victoria Tarimo. I'm a marketing manager for Shifa Pan-African Hospital. I think most of you know us. So thank you so much for having us here. Shifa Pan-African Hospital is a new private zonal referral hospital, which is located at Kinondoni, Msese Road, or we say near Makaburini, on your way from city center or Posta. on your left-hand side after Eco Bank or after Asa Microfinance Bank. We are located there. From Kinondoni, Manyanya Kinondoni, we are located on your right-hand side from Makaburini. Yeah, we are 260 bed capacity hospital with a vision of transforming healthcare. We mean transforming healthcare by ensuring that we provide services with international standards, but also with affordable prices. We do this also by having different in-house medical camp at Shifa, whereby we bring different expatriates from different countries such as India, Turkey, etc. Yeah, so we have done several camps, including urologist medical camp, yeah, whereby we did a complicated procedure, which is a Eurolift. BPH was very successful. Also, we did orthopedic medical camp. We did total hip replacement and knee replacement as well. It was very successful. But also we have several services, including executive health department. This is the first and unique department in Tanzania because of its features. This is exclusively for body checkup. This department is unique because it is a very standalone department, which is very well equipped with its own diagnostic equipment, with its own exclusive parking area, elevator, reception and waiting area. And also this one, you'll be provided with breakfast as well, because you come on fasting at least 8 hours. So we provide breakfast from our menu, and that also is included on the packages. This is on cash basis, and we have different packages from infants up to senior citizens. Yeah, so it is very affordable comparing with someone going outside the country, yeah, to do full body checkup, because people used to travel to India, South Africa, etc. to do this kind of body checkup. And the good part of it, we do partner with NM Medical, which is a leading diagnostic company in India, has more than 40 years experience. So even the medical report at Shifa is accepted worldwide. Yeah, so when you come to this certain department, it is standalone, as I said, because you don't go same route with patients. Yeah, and the equipment also is on one corridor, which are exclusively for this checkup. Other patients, they use other diagnostic equipment, which is located in ground floor. This kind of department is on second floor. It has its own X-ray machine. It has its own, for the Doppler ultrasound, it has its own mammography. It has its own DEXA scan machine. Yeah, it also has ECG and echo in one corridor. So you do just all the tests, 2 hours and a half, you are done. Then you can proceed with other activities. In the evening or a day after, you can just come to take your report, which will be given with our physician and a nutritionist at once. Yeah, so other services we offer at Shifa. We have radiology services, including MRI, which has 5.1 Tesla, which also has a capacity of doing a whole body scan for just 45 minutes. You can just do this kind of MRI scan. Also, we do have CT scan. We do have DEXA scan, as I said. We do have cath lab. We do have mammography, as I said. Also, we do have dialysis services, physiotherapy services. We do have cancer care unit, audiology services, orthopedic clinic. We have pulmonology clinic, general surgery, urology clinic, nutrition clinic, ENT clinic, dental clinic, and optical clinic. Also, we have variety of wards, including private wards. We have semi-private wards, we have general wards, and executive wards. Yeah, at Shifa, we do accept all major insurance cards, including NHIF. Yeah, so you can reach us through the following number, 0699 000 700, 0699 000 700. For more information, you can contact us outside there. We can give you more information about Shifa. Thank you so much for having us once again.
Thank you very much, Shifa Pan-African. I was at their booth and they showed me the executive for seniors. I thought I would be the oldest person in this group, but I don't know where Dr. Mebati came from, Naboth. Why did you come? Now he's 1 year older than me. He's sitting there. So we can go there. So any question for Shifa? Any question? So you should go and visit because I had the honor of visiting and assessing them at one time, and they are really good. I have not been there since they started, so I'll go and visit. The executive wing is very exemplary. Okay. Asante sana. Haya. Thank you very much. So now we have the gastroenterpreneur. What? Bito. We have, we have 10 minutes for you. You introduce yourself and then tell us about your thing. So natumia hii au? Okay.
Hii inaweza ikatoka? Nenda chini. Yeah, good evening. I think it's evening. Good evening. Yeah, I'm Binto, Mawazo Binto. I'm a lecturer at the Mwalimu Nyerere Memorial Academy, and I lecture or I'm employed in the Department of Economic Studies. I'm going to present here, but my presentation is based on my study for PhD, which actually I'm doing a PhD at the University of Dar es Salaam Business School, and my topic was the influence of business model innovations on customer value creation in the healthcare system. So I did it in the referral hospitals, zonal referral hospitals, covering KCMC, Mbeya, and Bugando. So during that study, I noted a theory and practice gap between entrepreneurship and how healthcare professionals make an application of that theory in their practice. But during this participation here from morning, I have noted some few things which I need to share with you before we go for this. So from those presentations and the discussion which has been conducted, I noted that there is a shifting trend in your area of practice. But also, there is a consistent outcomes in your initiative taken in dealing with the issues of your specialization. But there are some opportunities, including the advancement in your area of specialization, including also the diagnostic issues and the innovations and invention which are actually ongoing. Another debate is on the need for effective technology. No, the need for effective gastroenterology practice model. Also, I have noted the issue of diversities vis-a-vis holistic approach of actually giving our services given the guidelines. And lastly is something to do with the imaging dilemma between the standardized guidelines and the personalized care which you ought to provide to the patients. So these are the issues that I have noted And then the question comes, what should you do if you are to address those who are complying with the standards? The simple answer is that you have to think and judge entrepreneurially. So the concept entrepreneurially, acting or reasoning, has got several years, and the literature showed that it emerged in the 17th century. So during that time, the focus was to deal with poverty. But as time went on, it was noted that it can impact some other industries, including the healthcare. So it's because of that, it was contextualized in different industries. So we have like agripreneur, we have maybe marine entrepreneurship, we have the health entrepreneurship, and today I'm going to introduce to you, if at all you have never been introduced, they is to do with gastropreneurship. So if we are to think about those extension of entrepreneurship application, is that we need to reflect to the study which I did. We covered about 340 respondents, and the study actually was quantitative. So the results indicated that when health professionals, when they hear about entrepreneurship, what comes first is making money. But the problem was, if you go to your organization mission statement, is there any way to do with money? If you go to the vision statement, is there any way to do with money? According to the dissemination conference I have attended, in some of the key stakeholder discussion, we noted that there is no such a way. So if that's the case, we don't say that healthcare professionals are prohibited to make money, but your mode of making money is different from any other professionals. So if you think money is your first conception, the assumption that you are going to design a model which cannot be effective, particularly in the long run. Again, you need to understand that you have a personalized care which is emerging and preferred by most of people with interest in this area. So the question again is, what should we do now? The only thing you need to think about in such context is that you must think of contextualizing this theory. And when we contextualize is when we get at the healthcare as a sector, we have health entrepreneurship. That is different from agricultural entrepreneurship. It is different from maybe marine entrepreneurship. It is different from business entrepreneurship. So what you should decide to do is to know that if you think of doing better in your profession, you must think of trying to adapt these concepts related to entrepreneurial practice. So in my preparation then, we noted that even the healthcare industry globally is actually applying entrepreneurship. And this is the evolutionary trend from the 17th century to date. So there are some changes in each century according to the literature. I think you know much better. I think, did you present something to do with the AI? Someone presented about that. These are just the development. So we have development in different sections or different specialization, which any profession who is actually interested to be good must be adapting depending to the changes and the development needs from time to time. How do you adapt, or how do you contextualize? It will depend, actually, generally it will depend on what do you want to achieve, the objective of your decision. But once you have decided, you will build an intention to do something. So that intention will drive you to find an opportunity in order for you to achieve your intention. When you identify an opportunity, then you will go further to think about how are you going to utilize that opportunity by creating a relative model or a suitable model which can help you to deliver or to create a certain value and then deliver to the target audience. That process needs to be responding to changes along time horizon. So there is a number of issues that you must consider if you are to contextualize. One is the target audience. What is their need? And then after you have known that, that is actually through research, you now need to go in-house to find a way of designing a service, what we call a value, and then that will be required to be delivered using appropriate methodology of delivery. But mind you, you are not working alone as a professional. These things need to be done in a team. It's unfortunate that most of the meetings I have attended while trying to share these findings, I have never found any meeting which can be actually integrating maybe management people. Like here, we have people from different hostels, and here it's an hostel, so I can expect someone from the management to be here. Is there anyone? This makes a gap when we want to make a decision, because we'll be communicating to someone who has never heard of anything, but that person is responsible for approving your idea, your opinion, so that they can be honored by the organization. So try to be participatory. You need also to think of time. I've said these things started in the 17th century, and we are in the 21st century. So every time comes with some challenges and opportunity that is actually giving you the responsibility of acting in order to serve the community interests. We also need to think of the practice, a professional practice, management practice, social practices, and the presentation made here have also touched to some of this. So you can try to see how can you integrate these. There is a number of issues, the gastro-entrepreneurial ecosystem, regarding the what you want to do, where are you going to do it, who is going to do, who is going to receive the offering you are trying to give, or the service, etc., etc. But also some issues to do with the management, culture and practices, the leadership and the governance issues, as well as the values and ethics given your area of practice and the specialization. So this being the issue now, you will need to always think about the context, because I'm talking about contextualization as the main keyword, contextualization of entrepreneurship theory in the healthcare system. We say that is health entrepreneurship. If we need to go further to the gastroenterologists, we'll call it gastropreneurship. And the context we are talking about here, think about the history, not just the history regarding your specialization, but also how are we evolving as far as gastroentrepreneurship is concerned. We should think about the contemporary issues, the future context, as well as the temporal relationship between stakeholders and the other variables of interest in your area of specialization. The one thing which is most important is for you to understand what do you want to achieve. And that will set your objective, and from your objective, you will set some specific objective and come up with the specific activities that must be implemented, both entrepreneurially but also from your professional specialization. And lastly, you will design a model which can be most effective for you to achieve the intended objective, but also allowing some other stakeholders to benefit from your initiative. So with these few remarks, I'm thanking you for participating to my presentation and welcome you for specific issues of interest when it comes to problem solving, which requires integrating other professions. Thank you very much.
Thank you very much, gastropreneur. So this is very interesting for the gastroenterologist, and you should I think let's engage with him as he goes, because we had planned to finish by 15:30, but we have 3 pistol short presentations, so I will not allow questions, but until after. So we are going to have Tofik Sange. You have 5 minutes. Tausi, Dr. Tausi, 5, and Dr. Muya 5. So 15 minutes. Can you do it? If one can't do 5 minutes, should cede to the other. Sasa wengine mngesogea ukweli iwe rahisi kujoin hapa.
Good afternoon, everybody. I know we are all tired, but I will be very brief. I've been given just 5 minutes to end up with my presentation. So today I will be just highlighting briefly the importance of radiology in diagnosis of the gastric tumors. Okay. So radiology plays a crucial role in the management of the gastrointestinal tumors, aiding in the diagnosis, staging, treatment planning, and as well as monitoring responses of the treatment. So basically in radiology we are most looking at the TNM staging system, which is a gold standard for the disease classifications. And the TNM, the T stands for the extent and the depth of the primary tumors. The N stands for the involvement of the lymph nodes. It could be either regional or metastatic. And the M stands for the other organs infiltrations, example liver mets or bone mets. So the mostly used radiological modalities in our setups are ultrasound, fluoroscopic, computer tomography, magnetic resonance imaging, MRI, and nuclear medicine. So starting, I've omitted the ultrasound because ultrasound has a limited role. It has a role especially in the very small tumors where it can be easily diagnosed, but for the large tumors, ultrasounds, it's not a standard. So it is used mostly for the screening, like for the metastatic purposes. But starting with the fluoroscopic views, as you can see over here, I have some fluoroscopic images. These are the double contrasted images describing or giving an explanation of how we can characterize these tumors. So this is the first, I don't know if pointer is there. Pointer? Point. Can you see the pointer? Huh? Just so okay, so as you can see, this image, there is a projections of lobulated mass projecting from the base of the gastric wall from the ureter cavatum. Over here, another description signs is having an ulcers, gastric ulcer, which can be either due to the erosion of the gastric walls, or it could be maybe due to the normal benign ulcers. But it is identified by the pool of contrast. As you can see, centrally there is a pool of contrast. As well as in these pictures, we can see the irregularity of the wall, giving a mouth internal appearance, having irregular borders. And also in these pictures, you can see there is a constriction of the gastric lumen together with the loss of the ruga folds and irregularity along the mucosal wall. So these all features signifies there is ongoing gastric malignancy. So another modality is the CT scan, of which we can say there is a large polypoid mass which is arising from the greater curvatures and actually leading to the feeling defects of the contrast. The whitish part is a contrast, which is oral contrast being given to the patients. And another image, as we can see, there is a mucosal wall thickening within the lumen, having an irregular margin. So this is another image of the CT contrasted images. As you can see, there is an irregular luminal wall thickening on this side of the gastric, together with the liver metastasis. We have another modality, which is MRI, which is more likely the same as a CT, but in MRI it is more, it has more efficacy in delineating the soft tissue regions and infiltration of the mass, and knowing the extents, clearly delineating the extents of the depth of the tumor wall. So as you can see on the both images, there is a polypoid kind of lesions or mucosal wall thickening from the gastric walls. And also in this one you can see some infiltrations into the liver, suggesting of a liver metastasis. So regarding the nuclear medicine, I cannot talk much because we have the expertise here. Dr. Tausi will give a talk on the nuclear medicine, but the nuclear medicine helps in detecting the very early tumors, especially by picking up the FDG, and also it also picks up very small nodules which are being invaded by the tumors. So in today's areas on the gastrointestinal oncology, the interventional radiology cannot be laid behind, because they are actually a multidisciplinary efficiency in diagnosis, in creating a diagnosis, in managing the patient, and also having a proper follow-up. So interventional radiology plays a significant role in the different fields of gastrointestinal oncology, starting from the biopsy taking, and as well as administering of the treatment, for example, placement of the chemo port, and also embolizations, arterial embolizations, ablations of the tumors, and later on it can also be used, it can also guide in the gastric tube placements for the delayed gastric emptying and those who are having anastomotic strictures. Thank you.
Thank you very much, Dr. Sange. Dr. Tausi, please come, and since Sange has eaten some of your minutes, let's see how much you save.
Good afternoon. I should be very fast, but what is this? The issue is nuclear medicine is known but also not known. So I'll be brief, but the aim is at least you get 50% of it. Nuclear medicine, we do a lot in gastroenterology. Of course, in malignancy from esophagus down the gastric, pancreas, colon. But of course, today I'll just touch on gastric malignancy. But I want to at least to understand about PET-CT. Of course, there is conventional nuclear medicine and advanced imaging in nuclear medicine. And when I say advanced molecular imaging, we talk about PET-CT and PET-MRI. Since we don't have PET-MRI, I'll speak about PET-CT. But this is imaging. Nuclear medicine, we can do imaging as well as therapy. Here I'll just speak about imaging alone. So the principle of PET-CT, why we talk PET-CT is advanced imaging modality, is because of its technique of designing of the equipment itself. So we use radioactive material, which this radioactive material is specifically designed to target specific tissue or organ of interest. So this radiopharmaceutical, we call it a tracer. We combine it with the radiation. So this radiation is a positron emitter. So the positron is the radionuclide which unstable. When you inject it to a patient, within few minutes it decays, giving out a positron and the neutron. So that positron inside the body, once it interacts with the electron, it annihilates and produces two electrons which are parallel, opposite to each other. So it's opposite, one is like this and another one is like this, and we call this as a line of response. So in one incidence of interaction, that line of response. So you can have a lot of line of responses from inside the body when you inject to a patient. And this is detected now in a machine which is PET-CT, which has been designed with the special detectors to pick those line of response, which are now from the organ of interest. And here we are talking about gastric cancer and metastasis. Okay? So, so this is what we say about PET-CT, the principle, and the radionuclides, of course, which we use. PET is about function, but when you look at the function or biological behavior which is happening inside the human body, you need to be very specific. What are you looking at? So we tag with the specific those chemical materials, which of course we have glucose. That FDG is just a glucose. But what kind of glucose? So the normal tissue undergo normal glucose metabolism. But this is abnormal glucose because we have removed one oxygen. So once you inject it, undergo the first phase of glucogenesis, which are glucose 6-phosphate. After that, because there is no oxygen, it cannot proceed further. It just stuck in the tissue. So every organ or tissue which has high glucose metabolism, we can detect it. And we detect using fluorine-18. So this is fluorine-18 deoxyglucose. The fluorine-18 is the radionuclide, which I said is the positron emitter, which is seen by the PET camera. So we have a lot. So to target, because for the cells with the high glucose activity, with the which express this glucose transporter, of course, and specifically GLUT1 and GLUT3 are the one which we can see. But the rest, of course, those which do not or have less expression, then it becomes a challenge. But of course, FDG has become, like everyone knows, FDG, PET FDG, all right? But of course, there is a somatostatin receptor tumors which express somatostatin, and we target with the daughter, and we use PET, radionuclide, which is gallium-68. So you can see the gallium-68 daughter. It can be daughter TET, daughter NOC, daughter TOC. So those are somatostatin analog. But of course, you can also use gallium with the prostate-specific membrane antigen, that is for prostate, which express the PSMA, and of course, we have fibroblast activation protein. This is FAPI, labeled with also gallium 68. So these are the tracers. This is what I've said about fluorine-18 FDG. As I said, it's the current standard exam of choice. And of course, like in the preoperative follow-up, it has a report to have overall accuracy, positive and negative predictive value of 83, 78, and 84, respectively for gastric cancer. And yeah, it can, of course, modality of choice in detecting distant metastasis. But this is specifically for those gastric cancers which are glucose or FDG avid. So PET plays a role in, of course, staging, restaging, response assessment, and in follow-up. This is just to show the recurrent gastric cancer with that cervical lymphadenopathy. So FDG is is doing great job in this aspect. The group OTETAL did study, of course, indicating that you can use FDG PET-CT to check for responders and non-responders just during the interim PET. If you start chemotherapy today and after 2 weeks checking if your chemo is working or not. So decrease in uptake of 85%. For example, you have done baseline PET and after 2 weeks you have done another PET and there's a decrease by 35%. There is a response with accuracy of 85%. And this response, okay, 2-year survival was 90% in responders as compared to 25% in non-responders. So PET, or FDG PET can also be used, we say, in prognostication. You can predict the prognosis of the patient. And also, or if there is no response, you can also change your course of chemotherapy. So, but of course, FDG suffers because you know, it's a gastric, there is a lot of GI activity, mucosal inflammation, those which are using metformin, diabetic. So sometimes it's difficult, but also tumor pathology like gastric signet ring adenocarcinoma, gastric mucus adenocarcinoma, and the others. We do suffer like false negative findings. Now, this is just to show, for example, if you look in peritoneal carcinomatosis, and then this is signet ring carcinoma, you can see if you use other tracer, which is the fibroblast activating protein inhibitor, it has detected a lot of disease as compared to FDG, okay? Yeah, so thinking this is what we said in the morning about research. When we are doing PET-CT like 10 years back, this was a challenge for gastric cancer, of course in the other cancers as well, but the game now has changed. Fibroblast activating protein inhibitor, I don't want to go into details of the physiology, but it is expressed in most of solid tumors. Most of solid tumors, they do have fibroblast activation protein because of these cancer, associated fibroblast. So now we can label FAPI with gallium 68, all right? And the detection rate is brilliant as compared to FDG. So as I said, for signet ring gastric cancers with the equivocal findings in FDG, we can use FAPI. Of course, this is just to show how FAPI is. This is FDG. When you see black on the head, this is glucose because of the brain. And you can compare with FAPI, which is from the head is clear, there's nothing. So everywhere, if there is a disease, it's easy to see as compared to FDG. This is the heart, and the stomach is just down there. So sometimes it's challenging also because of the physiological uptake in glucose analog PET-CT. Yeah, so apart from other adenocarcinomas, of course, neuroendocrine tumors, we can image there's gastric neuroendocrine tumor where these somatostatin analogs works very well, very good. And of course, with if there's somatostatin avid that you have scanned, and you see the tumor is avid to somatostatin, then you can label the same daughter compound with the beta emitter or alpha emitter. So here we use beta emitter. Beta is therapeutic agent. So we can label with beta, and the lutetium-177 is the beta emitter, which produce therapeutic or radiation to the tumor, but you target with the somatostatin, which goes straight to the tumor. So this is kind of therapy which we do as well. Yes, this is just to show about we can tag the two. We call it the theranostic, that you use the same material, you just change the radionuclide of interest. If you want to diagnose, you put it either, of course you put positron emitter, and we use the same compound, you tag it with alpha or beta, then you use it for therapy, all right? This is theranostic, and it's a very personalized medicine. So it helps you to choose which modality of therapy as well you want. So sometimes you can have the tumor which is aggressive, but sometimes it also has cells which are well differentiated. So then you can image with this modality, maybe daughter and FDG, then you can combine now therapy which you want. And just to finish, what we have at home, because it's not now just a story, we have PET here. Government have invested a lot in this. We have PET-CT at Ocean Road, just 5 kilometers from here. And of course, with emphasis that we have cyclotron on site. So this it's not easy to find elsewhere. To have the cyclotron is industry which you can make, you can produce these radioactive materials. So we can, with our cyclotron is the commercial one, we can make FDG, we can make gallium as well, gallium-68. So, but also at the moment, we do have FAPI. So FAPI is available, it's not also a story now. So apart from FDG, we have seen the challenges of FDG, but we have FAPI here. So in all the solid tumors, we can image with FAPI, but of course others like lymphoma doesn't, it's not that avid to FAPI, we can use FDG, which is very good in lymphomas. Yeah, so we have daughter as well. So, and apart from the cyclotron, which is on site, but gallium, the good thing of gallium, we can import as a generator, as a can. So we can just elute and have radionuclide every morning. You can combine with your daughter or PSMA. So for those who are urologists, they send to us. Nowadays, we do a lot of PSMAs, but other, of course, gastric cancers, pancreatic cancers, we scan a lot with this FAPI. Yeah, so that's it. Thank you.
Thank you. I couldn't dare stop you, so I was sending my Dini, and because I enjoyed your talk, and I think you did very well, and I respect your daughters as well. Lakini Mwidini anapiga tu sana. Okay, so Dr. Skuzani, naomba uje umalizie. So we have seen from the management. How many minutes you do want? Because people want to go home. They can go.
I don't know, 10 minutes?
So
7. 7, okay. Let's go.
Use that one.
Oh. Hello. Thank you for the opportunity. I'll just go straight on the management of gastric cancer. So in short, management of gastric cancer depends on the histology, the grade, the stage, and of course, the performance status of the patient. Anyway, so this picture actually represents surgical part. If you choose surgery, they will depend on the stage. Stage 0, that's TIS, stage 1, stage 2, stage 3, stage 4. So all of these help us on the MDT. This is supposed to be MDT, multidisciplinary team to discuss. So what are the ABC of treatment? As I said, the stage, the histology, because 90% of the gastric cancer are adenocarcinomas, but there are others, sarcoma, lymphoma, and neuroendocrine as well. So I will talk mainly on the adenocarcinomas. So for the early stages, talking about TIS and TIE1, the main treatment here is surgery, endoscopic resection. And for those patients who are medically fit with resectable T1B or higher, NEN surgery with D2. So there are different types of resection. The surgeon will help me with this. I think there's a picture here. Yeah, this picture. So this picture tells us what is D1 and D2 surgery. So depending on which surgery is done, and most time the D2 is done mainly with the gastrosurgeon in Japan, where the gastric cancer is very endemic. For most of other parts of the world, they do D1, because this one is a bit of extensive surgery that is done, okay? So before the patient sent to us on the after the surgeon have seen them. So there's something called the perioperative chemotherapy. So this perioperative chemotherapy is there's a trial called the MAGIC trial, where the patient is given 3 cycles of chemotherapy and then assessed by the surgeon. They do the surgery and then they are sent back to the oncologist, where they get another 3 cycles of chemotherapy. So that is called perioperative chemotherapy, and it is preferred regimen. We usually give fluorouracil 5-FU, 5-FU, leucovorin, oxaliplatin. But there's also a float trial where patients are given this chemotherapy, and after that, they have to be sent to the surgeon. So this is 3 cycles of chemotherapy and then surgery. So apart from the perioperative chemotherapy, there is a neoadjuvant, where at least this disease is a bit bigger, so you cannot start with surgery, so you can start with the chemotherapy first, and then you can give radiotherapy and then surgery later. So there's a McDonald trial where after surgery, you give chemo and then you give concurrent chemo radiotherapy and then chemotherapy later. So after surgery also, there is something called postoperative management. So after surgery, you look at the histology report. So our treatment of cancer treatment most time depend on the pathology report. You decide now, what should I give, depending on the histology report. In the histology report, the pathologist has to tell us what was the tumor stage, depending on what's the story that was given by the surgeon. The pathology stage, pathological stage has to be reported. The nodal status has to be reported. Surgical margin has to be reported. The extent of nodal dissection. So the guideline, most of the guideline, they require at least 15 lymph node dissection. So now sometimes you find the report says 3 out of 3 positive nodes. Now that is substandard, but then 3 out of 3, it means all the lymph nodes that were dissected, they are positive. That means it tells you on the outcome. So you have to decide now, should you give chemotherapy, should you give concurrent chemoradiotherapy? All of those, they all depend on the histology report. And also we have to look at was the patient previously treated? What was the treatment in the previous treatment? And then you're looking at, in terms of the margin status, is it R0, R1, or R2? So that you decide on the type of postoperative radiotherapy. Another thing that we also look on the histology report is also the high risk features. The high risk features is also on the histology. What type of differentiation was it? Poorly differentiated, higher grade tumors, lymphovascular invasion, and perineural invasion, they are all high risk features. That tells you that this cancer will come back. So what should you give depends on all of this should be in the report. So if there are pathologists here, they should know what we want on the report. Yeah, this one I've already talked about it. There are different landmark trials that were done that guide us on the treatment, on the choice of treatment after surgery or before surgery. All of this has to be discussed on the MDT. The issue is, do we even have a proper MDT? The surgeon and us, we know the answer. Okay, thank you.
Thank you very much. Thank you for saving time, also for a very nice presentation. So these are part of the diseases of old age. That's why I was listening carefully, you see, and I couldn't stop them at all. And I'm so proud of Jamii Bora, his very strong team of experts. Now, I will allow 3 questions, a minimum of 1 for each. So it means if you ask a question for Dr. Sange, bas. Okay. 3 hands, 3 questions. Yes, please. Another hand? Yes, please. Another hand? Yes. Okay. Done.
Thank you very much. And my question goes to Dr. Muya, and I was interested with the nice presentation of the gastric cancer. My challenge with my patients, I usually find, especially in Africa, we encounter most of the patient with advanced disease. So having most of the patient with advanced disease, after we subject them for neo or special neoadjuvant or adjuvant therapy, I tend to have some complaints from the patient, and myself, I appreciate seeing them. Most of them, they have poor outcome from chemotherapy as well as radiation. And there's been a complaint from clients that can't we just go home without chemotherapy? And some of them have incurred more catastrophic health expenditure from the ongoing treatment that we subject them. And I came to realize most of our treatment, we depend on the Western studies that have been conducted from different tumor biology. Don't we think, and I don't know what's going on in the OS centers where you work, is there a time now we need to think on studying these African tumor biology so that we can find maybe the appropriate chemotherapy, radiation for our patient? That's what I was thinking. And in case you encounter these cases, have you reached a point there maybe you need to say we need to go for palliation or no therapy for such kind of patient? Thank you.
How many questions were those?
Two in.
Okay.
But 1 person.
That one.
Thank you. My question, I'm interested in the nuclear medicine part, in the treatment of GI, not specifically gastric cancer, but in the treatment of liver cancer, which is on the uprising. In the literature, I've read about Y90 as a standard for treatment of liver malignancy, and I'm interested into knowing that if Tanzania has a capacity of using nuclear medicine to use Y90 for treatment of liver cancer.
Okay, thank you. On this corner. UTAPATA.
Okay, thank you, moderator. I'm Dr. Ibrahim Koma, a plastic surgeon, and I'm here as a representative of the executive director, Muhimbili National Hospital. And I would like to know, Dr. Tausi, I'd like to know, one of the leading referral system in our hospital, the PET CT scan outside, okay? Therefore, to what extent, after establishing the PET CT scan at your center, to what extent have we reduced the number of referring this patient to the outside of the country?
Okay. Thank you. So for the responding, please come this way for the people online. One by one. Au zote za kwako?
Surgeon? Yes, okay. So you were asking on, is there a time that we don't give treatment? That was part of the question. So is there a time that we don't give treatment after the diagnosis? So if, regarding on the what are the indication of treatment, so if this patient has a metastatic and the performance data is very poor, we actually enroll those patients on palliative care. So palliative care now depends. Is it the pain that is disturbing this patient? So if it's the pain, then we give pain treatment. If it's bleeding, then we stop the bleeding if it's even possible. And sometimes for those who are able to afford the targeted treatment, for nowadays people don't have to die on cancer because there's a lot of targeted therapy. There is something called the next generation gene sequencing. So you're looking at the mutation, which mutations that this patient has. And on those mutations, there are different targeted therapies that has been developed that target specifically to that mutated area. So you can give targeted therapy, but they are not cheap, but they respond. Now here is the issue with the NHIF. Somebody said if it's not if it's not in the standard treatment guideline, it is not there. Now even though it is not in the NHIF or whatever treatment protocol, but how many Tanzanians do they have insurance? So at the end of the day, sometimes we professionals, we tend to condemn this patient that mgonjwa amekuja, he doesn't have insurance, you assume they can't afford. But they have money. So sometimes you just have to speak to you need to make family conference. Make sure that the family that are responsible for that particular patient, you see them, you discuss with them the stage of the disease, what is the prognosis, and what can be done, the option of treatment, whether it is inside the country or it's outside the country. I think that's what part of the question that, unless I forget one of the questions. Ongoing research. Yes, all the guidelines, they are from abroad, whether it's European or American. But sometimes you look at what we give and the outcome, you find like, maybe we have a different type of disease, completely different. And those are the areas that we need to do research. But now, still, we're looking at area that does our government support the research? Is there a specific sort of foundation or funding specifically for those research that will change the direction of treatment for our particular patients? So there's a lot of things that need, maybe it's high time that we profession have to penetrate in the political system to make sure that what we think is beneficial to us should be voiced in the political areas. That's all I can say.
Thank you very much for that.
Responding to the question about therapy, for gastric, I can say still we are on this surgery, chemo, immunotherapy, this targeted therapy, and of course we help in the staging, restaging, and prognostication. But yes, for liver, of course now first with the FAPI, it is doing very well to identify early with lesions for hepatocellular carcinoma, which of course FDG was not great on this. So FAPI now is doing well. Yes, on therapy, we have that capacity, I can say, of doing this radionuclide therapy. And because PET is new, just started, so these advanced radionuclide therapy, we are on the move to start. Of course, Dr. Latifa is not here. He's an intervention radiologist, because with the ETRAM 90, you need, because it's radioembolization. So you go through hepatic artery, and of course you need to also to do scan for the lungs, so that we penetrate through the, because we use the particles which can go through, and sometimes they can block and you cause emboli to, pulmonary embolism. So that intervention needs to have nuclear physician and intervention radiologist to do that. So the good thing, they are available now locally, interventionist, so can be done. The issue is now to import those new, because we are doing radionuclide therapy for thyroid cancers with the radioactive iodine. So these new tracers or new medicine, I can just call in very simple term, you need now logistic for TAIC to authorize and so on. But also the hospital now to those protocol for the management now to say, okay, now we are going for this. So this is the same as other therapy, because for now it has been a push, not only ETRAM 90 because we are here for gastro, but prostate. We have a lot of prostate cancer patients who are pushing for PSMA therapy, and now they are going abroad for that. We can do PSMA therapy here. So the issue is now, of course, we have been asked to follow some procedures which are administrative-wise, so that we can start. But of course, we are capable of doing that. We have been doing abroad these therapies. So, but let's wish for the best that with the PET now, this advanced therapy will start soon. Just for the government now support with the logistic-wise. With referrals abroad for PET-CT, Dr. Asha ananisikia hapa. yes, referrals to India, South Africa, and Europe was because of PET-CT, and of course, some of the radionuclide therapy. But since last year, somewhere last year, government has stopped sending, so all the government referrals has stopped, unless you are going for radionuclide therapy. And even that radionuclide therapy, we need to, it's not that easy. Of course, they come to us as physicians for us to say, yes, this patient really need and can benefit. Otherwise, government is no longer funding or cover that expenses. So unless, of course, people are going abroad on their own interest, just for comfortability that, okay, I'm going to India for PET-CT and but for government, we are no longer sending patients abroad. And now even the private patients are now coming to us, yeah.
Thank you very much, Doctor. And thank you very much, all of you, for your listening, for asking questions, making it lively. For me, although we started late and we finished a bit late, it has been an enlightening session for me. I'm used to facilitate policy meetings and whatever. This is more closer to home now where I started. So I enjoy it very, very much. I was not sure I'll manage it because technical, lakini kana vikumbuka vingine. So I appreciate that. So we have gone through, we have seen what are the GI, the burden of GI in East Africa. We have seen how we can manage, you can prevent, what are the policy implications, and now we have we had a CME showing the technology that's available for diagnosis and managing. This is a very good start. The organizers had planned to, that's why the acronym is TEAGIC. It's supposed to be the East African Gastroenterology Conference. So every year they want to introduce. So this year they thought we start with the symposium, one day, which I think it has worked very well. Many of you have been here, and so if it's interesting, I think would encourage them to engage you and maybe start planning for next year's, which should be a full conference with more sponsors, more participants, maybe 2 or 3 days, so that we can have, and should have really a truly East African face. So we thank you, Anthony, for making it here. Our colleague from Kenya was not able to come, but I hope next year you bring more people from Uganda, including Mzee mwenyewe, if we can come. We can give him to open. But also we must get people from other East African countries, and so we should prepare. So for me, the one-day symposium has been very, very interesting, very useful, and by you staying up to now, although we have overshot the time, but because we started late, so to me it's very encouraging. So as I'm glad that I was appointed to be moderator, thank you very much, and my work ends there. Now the two things which are remaining is recognizing some of the sponsors and the closing remarks. I hand back to the organizers. Asante. Kwaheri.
Mzee Ipuge, this is my close friend. So good evening, everyone else once again. As Dr. Ipuge pointed out that our intention was to do a conference, and we don't promise, but we want to say that we know 29th of May every year is a World Digestive Health Day. For those who know, for those who don't know, please take that. And we anticipate maybe coming year 2026, if we'll be kicking it alive, we'll have the perhaps the TEAGIC-2025 in form of a conference rather than a symposium as we have today. It is true that for those who have been here this morning, we have witnessed and listened and observed some sense of deep and enormous knowledge from our dear speakers, starting with the presenters, the panelists, and everybody else, the audience who participated in the live conversations and discussions we had this morning. It's a bit late, but we have, I think, one or two things to do to complete the session. One is for myself. I know Mzee Pugo will come to do the vote of thanks on behalf of the Jamii Bora organization. But before that, we'll have some sort of acknowledging some of the partners who facilitated our presence here, and maybe our coming, some of the people who have been supported to attend this particular symposium, and also going back home. So we'll have a number of partners who have supported the event, and to do that, I would request 3 people to help us in giving out the award, the certificates of awards to some of our partners. So I will request our dear Chief Moderator, Mzee Puge, is also his chair, is also sitting in the board for Jamii Bora, to come in the front. Sure, that's correct. But also, I want to acknowledge in house we have Yep. So also recognizing the support we got from TAGIS, the Tanzania Gastroenterology Society. Dr. Mroso, please step forward to help us in giving out the certificates. But also, importantly, Anthony flew from Kampala, from Entebbe, yesterday to come. He's also come forward for the event. But also, importantly, I would request we have a partner institution we work with, the Muslima Medical Fund. I know the CEO is around here. Dr. Shamahita, please come forward quickly. But also in the house, I know we have the president from MEWATA, Medical Association of Tanzania. Please, Dr. Zaituni, come forward quickly. So we will recognize some of the partners in order of their intensity in supporting the event, and I would call right away a representative from Headway, our main sponsor of the event. Leo or Jesse, please step forward, and you will receive the certificate on behalf of Headway, please. Pitani. Some claps for our main sponsor of the event. Thanks, Leo. Thanks, Jesse, for your support, and we hope you will pass our regards to some people back to the Headway headquarters back in China. While Headway is finishing, I would like someone from RIMA, representative, to come forward to receive the certificate on behalf of RIMA East Africa. RIMA East Africa, Bruno. So Bruno is representing RIMA East Africa, who they are the distributors of the UBT machines. So anyone in the name of the machines, RIMA East Africa is the sole distributor of the UBT machines in Tanzania and Kenya, and also South Sudan as well. Thanks very much. I would like someone from Shifa. Oh, some memories. So Shifa, Pan-African Hospital, will be next, and some claps for them as well. They all supported our event. Representative from YES. Anyone from YES? YES Tanzania, please come forward. YES Tanzania, they've transitioned the name from TIGO, and as of today they supported the internet connectivity in the room and enable us to stream the event live over the globe. From then, TAGIS. So, Mroso, with you? So Mroso should cover because Mroso is a dignitary. Some clubs also for TAGIS, they have been instrumental in supporting us make sure this event is possible. So now, Anthony, you should step also forward for the Uganda Gastroenterology Society, and perhaps the award, the certificate will go back to the president back in Uganda. Pass our regards as well to the people from Uganda, including Mzee as well. And lastly, anyone from East Africa Rubber should prepare to come forward. East Africa Rubber Stamp. So East Africa Rubber Stamps also supported the graphics and for videography, photography of the event, and also they supported the streaming of the event live outside the room. So quickly after that, I would like the dignitary to remain, but also some rest of the presenters and panelists of today, please come forward for the photo. The presenters, Ahmed, Lutfi, Minto, Taufik, Dr. Tausi, please quickly. A photo with Dr. Moya, JC, in front, Leo, Bruno, for the memories that we were here on that particular date. So lastly, I know Mzee Pugi will do the vote of thanks, but because I'm standing as the Secretary for the Jamii Bora Health Service Organization, which organizes the event, I'm thankful to everyone who has been here since morning until this time we close. And as Dr. Komba said earlier on, this first meeting should be a cornerstone to embark on further journeys. We did gastro this year around. We are thinking of having another conference sometimes back at the end of the year. But also we will venture into other disciplines like ophthalmology, oncology, and other specialties to see if we can have more sessions like this one, having deep understandings, sharing knowledge and experiences as we did today. So one last announcement before I welcome Mzee Pugi, who will come here to give a vote of thanks. On behalf of our board chair, Dr. Muhammad Ali was here, and he left as he had something to attend quickly. One was that the reminder, please give us your name, MCT number, and signature. But also, I would like the Jamii Bora members in-house to spare at least 5 minutes, stay behind while others are leaving, so that we can give out some simple announcements before we go out. Okay. So I'm told also, apart from the certificates and awards we gave out to our sponsors, the organizers are also preparing participation certificates to all the people who attended the event. So if you registered in the system, so we have your email and a WhatsApp number, we will share an electronic certificate direct to your email. So if you are in-house and perhaps you couldn't register on time, please don't leave out, go to the desk outside the door, and please put up your name, your email, and perhaps a WhatsApp number so that we could share the electronic certificate to you as well. Having said that, I have no more. Just to ask the Jamii Bora members to remain aside while others are leaving, and Mzee Pugi will come here for the concluding remarks, and his words will mark the closure of the TEAGIC-2025. Mzee Pugi, Karim.
Thank you very much. Just as you haven't seen me here before, because now I'm standing as a board member of Jamii Bora, and on behalf of the chairman of Jamii Bora, Dr. Mohammed, who has to travel to Rwanda today, so he left here to go. So my first appreciation is for all the participants who registered and came to participate in this meeting. Without you all, this event, however the idea was good, however the the cause was noble, would not have happened without you all being here. So I would like to recognize, applaud, and thank you very much for accepting to join us for this event. So this is for all of you. Jamii Bora came with the idea and worked with the approach some of the sponsors, some of them who are giving certificates today. Most of them are appearing in this board. They held us, we gave them a hand, they gave us a shoulder, so we were able to organize this and go. So although we registered and some of us maybe paid some registration fee, but without their contribution, we would not have managed to reach here. So I thank you all the sponsors who joined Jamii Bora in this event. Thirdly, those who accepted to present, because now you can have the participants, you can have the organizers, you can, if there's nobody to make the time to prepare a presentation and come and stand here and make presentation, again it would have been fruitless. So I thank you all, because you made it, when you have the idea, you don't know how people will accept. And seeing people sitting until this time, it means your presentations were worthwhile. That's why you can start thinking of the next conference for next year. Then lastly but not least, the Tanzania Gastroenterology Society. Without your accepting, because you are the host, Jamii Bora has some gastroenterologists as members, but we cannot claim to be the gastroenterology people. I mean, it would be very fun if it was only Jamii Bora, then people will say, why Jamii Bora? Because you are, but you are joining us, being part of the organizing committee and part of the whatever, you have made it very, that's why we have people from Uganda, because if Uganda was here, Uganda Gastroenterology Society, and there's no Tanzania Gastroenterology, wangeshangaa, si ndio? So I'm very much pleased and appreciate and recognize your joining in this. But also the other organizations which were recognized, like TAMWA, like Muslimat, but also Dr. Anna Asha, since you are here, but also you are from the ministry, so in your own capacity, you will pass the message to the ministry that things are happening, sindio? And also we have the representative of director of Muhimbili National Hospital, so we have the leadership of the health sector, various people. So I would like to thank you all for coming here. We have, I think the purpose of the conference has been achieved, and I would like to congratulate you, Dr. Muhidini, for being steadfast. When you called me first, I said, can we manage this? But I think we have done it, and I hope with the Tanzania Gastroenterology Society, Uganda, and Kenya, and the others, we should start planning for the next. And members of the organizing committee will appear from those who participated in this symposium. So I think the media people also have helped us, that there are people who are outside here we are able to hear and follow us. Na watambueni, asanteni sana. Now with those appreciation, I don't have much to say because we have learned. We have got CPD points. We have got the knowledge. We know now PET scan is here. We don't have to go to India like Dr. Mbembati went. So now we'll do it here. Sawa sawa, Dr. Nani or PET scan, Tausi. So we'll have, so I would like to thank you and say, with those few remarks, the Tanzania, the East African Gastroenterology Symposium 2025 is formally closed. Asante sana.